Okay. Good morning, ladies and gentlemen. It's a pleasure and an honor for me to open the session in which the Consortium of Clinical Experts on Vanishing White Matter will for the first time present itself to the public. In this opening, I will discuss the need for a consortium, the mission, the choice of consortium members, its support, its associations, its achievements so far, and the program of today. So, Vanishing White Matter is an ultra-rare progressive disease without curative treatment. And in 2001, the genes associated with the disease were found, and since then studies have been ongoing on its mechanisms. And with that, insight into how Vanishing White Matter works has increased, and we also have detected targets that can be addressed with therapeutics. And that instigated the interest of multiple companies, and currently multiple drugs are in different stages of preclinical or clinical development. And with that, multiple companies started to contact us because they wanted to talk to us about preparing clinical trials. Now, this all happens mostly in 2018-2019. And we started to be worried about multiple trials for Vanishing White Matter overlapping in time, competing for patients. And what we were worried about is that in the end, all trials might be underpowered and might fail, which would be a terrible waste of efforts for patients and families. It would be a waste of money and efforts of companies, and also a waste of efforts of doctors. We also worried about accessibility and affordability of new drugs for Vanishing White Matter patients worldwide. We would not want patients in poorer countries to be left behind. So we founded an international independent consortium in the fall of 2019. And we wanted to contribute at the interface between companies and patients to optimize the setup and organization of trials and impact development of therapeutics. The mission of the consortium, as we agreed on, is to enable and accelerate therapeutics for Vanishing White Matter, aiming at accessibility and affordability for all patients. To this purpose, we established an international collaboration which engages partners to provide unbiased analysis of different therapeutics using smart trial design to address recruitment challenges of this rare disease. It's my pleasure and honor to present to you the 9 members of the consortium. The clinical scientists were selected because of clinical and research expertise in leukodystrophies, in particular Vanishing White Matter. They needed to have an excellent publication track record on the subject. And they were also selected for geographic representation. And we chose them from countries that follow the good clinical practice guidelines. As you can see on the right upper corner, those are the locations they come from. All clinical scientists have an excellent and long track records on leukodystrophies. So I'll not mention that for any of them. I'll just mention for everybody his or her specific focus. Dr. Josh Bonkowski works at the University of Utah Health in Salt Lake City, and he and his co-workers excel in exploring large databases to abstract very useful information like incidence of leukodystrophies, related genetic variants, and leukodystrophy-related healthcare cost and healthcare access. He has a zebrafish that he uses to model leukodystrophies. Dr. Adeline van der Veer has a special focus on Aicardi-Gouttière syndrome and on HABC. She has excellent organization skills, which led to the development of the GLIA consortium and the GLIA clinical trial network. I forgot to tell that she works in Children's Hospital in Philadelphia. Dr. Raphael Schiefman used to work in Baylor Research Institute, and he moved to 4D molecular therapeutics very recently. He's one of the founding fathers of the definition of Vanishing White Matter, and he has continued to work on the disease ever since, next to other leukodystrophies. Dr. Inge Kregelo is working in University Children's Hospital in Tübingen, Germany, and she has a long-term focus on cerebral palsy, metachromatic leukodystrophy, and other lysosomal disorders. Dr. Enrico Bertini works in Children's Hospital in Rome, and he has worked on numerous different rare genetic neurological disorders. His special focus is on mitochondrial leukodystrophies. Dr. Geneviève Bernard works in McGill University Health Center, and she has a special focus on hypomyelination and 4-H leukodystrophy. She and her group have found all genes related to 4-H leukodystrophy. Dr. Ali Fatemi is Chief Medical Officer of the Kennedy Krieger Institute in Baltimore. He has a special focus on peroxisomal leukodystrophies, especially ALD, and in the last years also an extensive team working on LBSL. Dr. Nicole Wolf works in the Amsterdam Leukodystrophy Center, and she has a special focus on the definition of novel hypomyelinating disorders and their related genes. She also likes to work on long-known disorders like Babezius-Merzbacher disease and metachromatic leukodystrophy. I'm also working in the Amsterdam Leukodystrophy Center. In the beginning of my career, I mostly worked on MRI interpretation, definition of new leukodystrophies, and identification of their genes. My special focus is on vanishing white matter and MLC. We could not work without support. We get a lot of support from the Industry Alliance office in Amsterdam. Dr. Arjen Brussaert is the director of the Industry Alliance office and also director of Amsterdam Neuroscience. He is very much in favor of the consortium and allows others to help us. Pieter van Bokhoven is director of business development and also knowledgeable in the field of trial setup. The most important person for us is Priska Leverink. She is business developer and she has a focus on leukodystrophies. So she helps us a lot with multiple companies in the development of testing and also trial development. Priska knows what she's talking about because she has a PhD on stem cells in vanishing white matter. So she really has inside knowledge. So she's the best business developer you can think of. Peter van der Ven is trial statistician and he is specialized in rare disorders. We are proud to be associated with the United Leukodystrophy Foundation, and I'd like to mention the names of Bob Rauner and Donna Squirrot. We are proud to be associated with the European Leukodystrophy Association, and I would like to mention the names of Guy Alba and Elise Saunier. And we are proud to be associated with the VKS in the Netherlands, and that's an organization for patients and families with metabolic disorders, including the leukodystrophies. And I am glad that we have Hanka Dekker on board. The achievement so far. We video meet every 4 weeks for 2 hours. So that's quite something. And that made us very productive. We have formulated a mission statement. We have written an opinion paper on therapy trials in vanishing white matter. We've submitted it to a journal and we got back a favorable response. We are in the process of revising the paper and hopefully submit it again soon. We are in contact with multiple companies on diagnostic testing, drug development, and trial design for vanishing white matter. We have in Amsterdam since long a registry for vanishing white matter, and we are working on changing the governance so that it will be an open registry and also other people can obtain data from it. And I'm very proud of point 6. With great help of the Industry Alliance office, especially Priska, we worked on a consortium website. It's just launched, it's still in progress, but you can find it and I invite you to visit it. This is the program of today. So right after me, Josh will talk about clinical presentations of vanishing white matter. Then I'll say something about therapy targets. Then Peter van der Ven and Pieter van Bokhoven will talk about approaches to trials for rare disorders. Priska will talk about the interface between medicine and industry. Geneviève Bernard will talk about the interface between medicine, patients, and families. Donna Squirrett will talk about the perspectives of Vanishing White Matter families. We have a break. Then Adeline van der Ver will talk about a burden of disease inventory in AGS, and Ingeborg will do the same for MLD, which we can use as an example, and we actually started a collaboration on the subject to an inventory for Vanishing White Matter. Dr. Enrico Bertini will talk about his experience for clinical trials on rare neurological disorders. And Dr. Menno Stellingwerf, he's a PhD student, will talk about how we plan to change the Vanishing White Matter registry. And after that, at the end, we'll have a general discussion. This is what I wanted to say, and I'll share my PowerPoint presentation, and I would like to invite Dr. Bonkowski to give his talk.
Good morning, everybody. Thanks, Dr. Van der Knap. Very nice introduction and exciting for the consortium to be out in public and everyone to be hearing about it. Let me hope that I can get my screen to share and all this to work. Always exciting. And okay, hopefully everybody sees the screen okay. So I'll be talking about clinical manifestations of Vanishing White Matter disease. So leukodystrophy with Vanishing White Matter disease has been known historically by a couple of other names as well that folks may have run into. It was also has been known as childhood ataxia with CNS hypomyelination, so CACH. And one of its early descriptions was also in a population of indigenous Canadians, Cree leukoencephalopathy, where it was discovered also in that population. So Vanishing White Matter disease is a autosomal recessive condition. It's usually inherited, meaning that neither parent is affected, but that when they have a child, they have about, typically can have a 25% chance that a child might have the condition. It's caused by genetic changes or mutations in there's 5 different subunits of something called EIF2B, and these mutations then lead to the disease. And so on the left side of the screen here, there's pictures of MRIs, and so the top row of panels shows someone with Vanishing White Matter disease, and then the panels below show a child who doesn't have disease. And so the things that are kind of remarkable to look at in this panel B, the white matter has this very bright white appearance, so it's a very striking appearance on MRI. And then the name itself, the Vanishing White Matter disease, you can see in panel C, where the white matter itself tends to cavitate and actually gets lost. And so back in 1997, Dr. Van der Knap here on the call with us today came up with the great name that we all know this disease by. See if I can make this work. So some of the other kind of interesting features or unique features of Vanishing White Matter disease, which really help us understand the condition and have led to insights into the disease, as well as to kind of knowing how to recognize it, is that relatively minor stressors, things like falling off a bicycle, so kind of minor head trauma, having a fever just from like a cold, or even just being having a surprise or a scare, can lead to fairly severe deteriorations in people with the condition, and even lead people to fall into coma or in severe conditions to death. And so this is a kind of a hallmark feature of Vanishing White Matter disease, which can help us differentiate it from other leukodystrophies. So how does one get Vanishing White Matter disease? So again, it's an autosomal recessive condition. So the child can only get the condition when both parents have the mutation. So usually the parents are unaffected, but then the child has a 1 in 4 chance or 25% chance of getting both affected copies of the gene and then getting the disease. It's a complex, a protein complex that works together called the eif2b complex. And there's 5 different subunits. So any kind of combination of mutations can lead to the disease. It's also possible that the parents might not carry a copy. Something called a de novo mutation can occur, where it happens kind of spontaneously or out of the blue, but that's more rare. So it's this, again, the gene that's affected, or the protein that's affected, is called the eukaryotic initiation factor 2b. It has 5 different parts to it, so like kind of like a Lego piece. And so there's 5 different genes that make those 5 different parts of the protein. And the job of this protein in the body is that it helps make other proteins. And so all of our bodies are made of proteins. So obviously it plays a very important part in how our body works. It turns out, interestingly, that this protein, this complex, is also very important for how our body responds to a type of stressors. And this stress response is called the ISR, the integrated stress response. And we'll hear more about that as we talk about therapies, because that turns out to be very important for how therapies have been developed. So how does one figure out that someone has vanishing white matter disease? So really now the key is to send genetic testing. And of course, one can send single gene testing, panel testing, whole exome, whole genome, and depending on where someone lives, the types of insurance, the type of testing is available. These are all good options. Right now in the United States, one of the testing companies is offering a panel testing for Luca disease at no cost. And so that's become a great option for families, but really consulting with a specialist to help figure out what test is best in your situation is what I would recommend. So how common is vanishing white matter disease? So that's a great question. We're not 100% sure. And I think depending upon different counts, we get really wide range, as low as like 1 in 50 to 80,000 live bursts. And so that's from work from Dr. Van der Knap and colleagues in the Netherlands, to much rarer, maybe 1 in a million live bursts from database estimates. And so I think the problem that we have run into is that as we learn more about the disease, we're seeing more people with it. We just don't have a sense of like if there's lots of patients being missed with it. So it's a very, it's a big range, but probably more people than we realize have the condition. If we use the lower estimate of 1 in 50,000 live births, then we would roughly expect that in Utah, where I live, that there'd be about 1 person a year born with the condition. In California, we'd expect 6 people each year born with the condition, or New York with 4. So that's at the high end, and at the low end, of course, it'd be much fewer. So I think it gives us a sense of what we'd be looking for number-wise. So who can get the disease? So basically, it can affect every age, and that ends up being fairly tricky because perhaps there's more people out there with the condition who don't even realize it. Some infants are born with a very severe form where they can die shortly after birth. And then basically, depending on the type of mutation, the kind of how the protein's affected, infant, you can have disease onset as an infant, or as a toddler, as a child, a teenager, or even adults are sometimes showing up with their first symptoms of disease. There's even often families where they don't realize they have the condition and they're essentially asymptomatic, but it turns out that they have the genetic condition and at some point start to develop symptoms. So what kind of symptoms does vanishing white matter disease cause for someone who has it? So it causes loss of the white matter, and the white matter is critical for how our nervous system works. It carries signals from one part of the nervous system to another. And so obviously, if you are affecting those signals, then things aren't working correctly. And so really the symptoms depend upon the age of onset and on what part of the brain is affected. In general, people, once the disease starts to affect you, you kind of slowly have worsening, but sometimes there can be some improvement or stabilization between episodes of worsening. But unfortunately, it tends to be that most people kind of slowly get worser with the effects over time. So the kind of things we see is that there are different aspects of neurologic function worsen. In little kids, this is often seen as developmental regression, meaning they lose skills they had before, like being able to walk. Oftentimes, people can develop spasticity or tightness. In more severe cases, people develop, can be hospitalized with lethargy or changes in mental status or even coma. people can be at risk for seizures. And then, of course, there's effects on how you function with your motor skills, like walking or going up and down stairs, your cognition. It can also affect your ability to kind of deal with stressors. And so it can cause psychiatric symptoms like depression or anxiety, or more severe kind of schizophrenic type symptoms. And of course, in the most severe cases, it can lead to death. So this is a very nice paper, information from 2018 that Dr. Hamilton and Dr. Van Erkap and their group in the Netherlands, where they looked at the age of onset when people first had the symptoms of vanishing white matter disease. And so the height of the bar shows how many people were affected, and the bottom shows their age. And so you can see that the biggest number of people when they first had symptoms was in children under age 10, and even really like even under age 5. But then you can see that there is quite a long group of people who are affected even up into their 20s and 30s and later. So again, very variable. So what are the different forms of vanishing white matter disease? So again, we briefly mentioned this already. And this is where we talked a little bit about how the age of onset often correlates with how severe the disease. So the antenatal, meaning before birth onset, usually is very, very severe. Oftentimes the infant can be stillborn or die in the first months or year of life. Infantile onset, meaning the first year or two of life, again, also a very severe form. It's very difficult to, it's a very sad situation where the disease progresses quickly. The early childhood onset, oftentimes the child will have a period of normal development, but then might start to have symptoms. Sometimes these are the kids who can have kind of the episodic worsening with like a fever. And then the later childhood or adolescence and then adult onset tend to have a more kind of early aspects of the life, tend not to have any effects, but then present with some symptoms, sometimes again precipitated by some event. Interestingly, I've seen a fair number of folks now who have migraine headaches. The migraine headaches don't seem to kind of correlate with the disease worsening, but it's something that tends to be quite bothersome. So this is from the same paper in 2018, looking at the how the disease progressed over time. And it's a little bit complicated, but the point is that if you the different colors on each graph show how people got worse over time. And so if it's going down, then it means you're getting worse. And so the different colors show the age of onset. And so unfortunately, you can see if you have an age of onset with the black color, meaning that your age of onset was when you're a year of age or less, that progresses very quickly. Whereas if you have a green age of onset, meaning that over age 18, it's a much slower progression. And so again, just emphasizing that the age of onset tends to correlate, not perfectly, but with how things get worse. So again, how does one diagnose or figure out that you have vanishing white matter disease? So usually most people are identified because they have symptoms, and then a brain MRI is really critical. There's some key features on brain MRI that can really are characteristic of vanishing white matter disease. And then to confirm it, which is very important, is to do genetic testing to find the gene mutations. And so sometimes working with a specialist is necessary because there can be some aspects of genetic testing that are more subtle. So the imaging, these are some pictures of brain MRI. So again, brain MRI is the best way to look on the imaging. And so in panel A, the white matter has this super bright appearance. It's very striking. Oftentimes the MRI, the radiologist will call in a panic because they'll see this MRI and be like, whoa. And so when you see that MRI, oftentimes that's the first clue because the MRI looks so different. Oftentimes it looks much worse than how somebody is doing. And then on the other thing that's often seen with the MRI is this thing called stranding. And so it's kind of looks almost like a cobweb type appearance in the white matter. And that's also something that's more seen. It's seen in a few other conditions, but again, it's more common in vanishing white matter disease, and again, kind of a unique aspect of the MRI appearance. So there's many more things, and that's why I hesitate to say more in front of Dr. Vanderkamp, but those are the things that for me helps me be like, oh yeah, this looks like vanishing white matter disease. So is there newborn screening for vanishing white matter disease? So it's not currently in the United States on something called the RUSP, the Recommended Uniform Screening Panel, because there hasn't been a treatment for it, but as we'll be hearing about it today, there's a lot of excitement about treatments that are coming. And so newborn screening may be something that we as a community need to work on, because the earlier we can diagnose someone, the more helpful the treatments and interventions we do can be. So I think this will be a task for us over the next 5 or 10 years. Is there a treatment yet? So this talk has changed over time. So there's not a treatment today that's approved by the different regulatory agents, but I am very hopeful that that this talk is going to be very different in a year or two, where we can offer treatments. However, I think the important point is that even though we haven't had a cure, there's still things we can do to help people in our families or our patients to treat symptoms and give a better quality of life. One question that often comes up is, what is the role of supportive or preventive care? So we obviously want to avoid things that would make the disease worse, like playing tackle football, where you might have head trauma in the United States, but it's unclear how important the role of things like steroids or other anti-inflammatory medicines would be to prevent worsening of disease. So this time we can't really give a strong recommendation about that. So what are some of the medical issues that folks deal with? So there's a wide range of medical issues ranging from pain and seizures, spasticity. I think working with a good medical care team is really can help manage these things so they don't affect the quality of life more than it needs to. We would like to emphasize prevention. So things like getting the flu vaccine, standard vaccines, and even the COVID vaccines we think are important, because you can imagine if you get sick with anything, it can cause this kind of acute precipitation of worsening for someone who has vanishing white matter disease. Again, please avoid playing sports or other activities where there's the opportunity for something bad to hit your head. So again, symptom management a little bit more. There's a wide range of options for how to treat the disease, even in the absence of a cure. So doing things like physical and occupational therapy, treating the spasticity to make the spasticity as little a part of someone's life as possible, trying to improve a lot of times if there's problems breathing, using oxygen therapy or other types of therapy to improve lung function, making sure to treat any seizures. And then, although people often hesitate about this, making sure you keep someone's nutrition as good as possible. So sometimes if swallowing becomes an issue, we would say, don't be afraid of feeding tubes or assisted nutrition if that's something that will improve somebody's quality of life. So there's a lot of family and other support organizations for vanishing white matter disease, a lot of experts who will bend over backwards for families across the world. So please don't hesitate to contact the people on this call or these other groups shown here in this slide. So the prognosis is something people always ask about. I think historically, of course, when folks go onto Dr. Google, it's quite spooky, right? But I think that overall, we want folks to have hope. And so we do want to be realistic, but we also want people to have hope. So I think it's a delicate balance, both to be hopeful about treating the disease and dealing with it, but also being realistic if the disease is progressing and getting worse, that to make plans that correspond with reality. So what are some of the last messages to take home? So I think vanishing white matter by kind of unsophisticated folks can be mistaken for other conditions. I've had folks show up who've been diagnosed in the past with multiple sclerosis. So it can look like other types of conditions. Another thing is that the MRI, when you get that first MRI back, it can look much worse than how somebody's doing. So when the radiologist calls in a panic, you don't need to panic also. If you find one person in the family who's diagnosed, because there's a risk for other, if one child is diagnosed, then there is a risk, a 1 in 4 risk that any other kid in the family could be affected. So please be sure to test other family members who could be at risk. And then diagnosis, including a genetic diagnosis, is important because there's clinical trials coming And we want these clinical trial options to be available for everybody in the community. And thanks for your attention, and I look forward to hearing all the other great talks today.
Thank you so much, Josh. It was just wonderful. And also seeing your environment being in the car, it's just something admirable. Thank you so much. And for people in the audience, the general discussion will be at the end. So I will now start sharing the next PowerPoint. I hope you all see it. Is that so? Do you all see it? I assume that you see it. And
Yes, we see it.
Okay, thank you so much, Donna. And I'll talk about therapy targets in vanishing white matter. What's needed for identification of therapy targets and for preclinical or clinical development? One is you have to know the disease, and Dr. Bonkowski talks about that. You have to know the cause of the disease, and he talked about that too. You have to have insight in the disease mechanisms. I'll say something about it. Then we need disease models for testing those promising therapy targets. And we need to identify those therapy targets and then subsequently test them. I'm not going to repeat what Dr. Bonkowski said. I just wanted to share this one slide on the clinical picture with you to indeed say that for clinical trials, we need to know the course, because the clinical course for patients with a very early onset is very fast. And with later onset, it spreads out. So in designing clinical trials, you really need to pay attention to what the disease is. And in the case of vanishing white matter, you need to specify what the age of onset is. Because in trials, you probably need to make homogeneous groups and stratify for the age of onset. Then Dr. Bonkowski also showed this graph for age of onset. And that's all well, but what's important to realize is that the current age is very different from the age of onset. So this graph makes you feel like vanishing white matter is something only seen in very young children or almost only. But if you look at the current age of the living patients, you can see that 2/3 is 16 plus and 1/3 is minus 16. So for clinical trials, you need to realize that patients living longer become older, and patients with a very early onset may die soon, so they don't contribute so much to the numbers. So for clinical trials, this is something to consider. Then we go to the cause of vanishing white matter. Vanishing white matter is caused, as Dr. Bonkowski said, by mutations in 5 genes, EIF2B125, and they encode the subunit of EIF2B. Now, this is an enzyme, and it's essential in the translation of DNA, mRNA to proteins. So we call this process translation. And without EIF2B, there's no translation, no protein synthesis, so no life. That means that mutations in patients decrease EIF2B activity, but the activity of EIF2B needs to be sufficient to survive. So all patients have remaining activity, or it's only decreased. It's not only conditional for protein production, but it's also essential in the cellular stress response. The cell stress response is a general response of the cell to stresses. And with stresses, I mean physical stresses, like febrile infections, head trauma, starvation, and things like that. Then what EIF2B needs to do is to stop the process or downregulate the process of production of novel proteins. Novel protein production takes a lot of energy, and the cell needs to spend its energy on something else like survival and recovery. This is the integrated stress response. And here you see the stresses that, as Dr. Bonkowski pointed out, also may cause deterioration in the patients. It's fever, viral infection, and this is called protein folding stress, head trauma, heme deficiency, amino acid starvation, and they all do the same thing. They lead to the phosphorylation of another initiation factor, EIF2, but then tightly binds EIF2B, and in that way inactivates it, and that leads to inhibition of protein synthesis. Now, this is a more complex cartoon, but it's about the same. Here you can see EIF2B. Here you see the stresses. Heme deficiency, fever, head trauma, I forgot to include it, amino acid starvation, protein folding stress. They activate these enzymes. These enzymes phosphorylate EIF2 that then tightly binds EIF2B, inactivates it, and it has two downstream effects. General protein synthesis is down, but the ATF4 transcription response is activated. And this transcription response is going to determine whether the cell is going to recover this stress and proliferate again, or whether the cell is going to die. And the ATF4 transcription response comprises many different factors, and one of them is GAT34, and GAT34 opens a feedback loop that then dephosphorylates EIF2, and with that abates the cell stress so that the cell is out of stress again. Now, in vanishing white matter, there's nothing here, but EIF2B activity is always down because of the mutations. We have not found anything wrong with protein synthesis, so the remaining activity that I mentioned is sufficient to guarantee general protein synthesis. But the ATF4 transcription response is always on. So cells are always deciding, in particular in the brain, are we going to die or are we going to recover? So this is not good. And then imagine what happens when stresses are added, those stresses. If they are occurring, then you see a hyperreaction of the ATF4 transcription response. And I think this is it what explains the chronic deterioration in vanishing white matter and then its sensitivity to additional stresses. We have been able to confirm this, as you can see here with this brain tissue of vanishing white matter patients and vanishing white matter mice. And what you see here is that those factors in the ATF4 transcription response are all up, and that the phosphorylation of EIF2 alpha, this is the feedback loop, is down, meaning that the feedback loop is activated. And you see the higher the factors in the ATF4 transcription response, the sicker the disease is, because this is a mouse early in the disease course, and this is at a humane endpoint, and then it's really sky high. And also the more mutant the mouse is, the higher the ATF4 transcription response is. So the ATF4 transcription response is really something that's important in the disease mechanisms. So the fourth thing I mentioned was we need models. We made mutant mouse models with mutations in EIF2B4 and 5, and we chose human mutations that are associated with severe disease, and we crossbred them into double mutants. So you see here, this is the 2B4 homozygous mutant living 600 days, 2B5 living less than 300 days. This is the 1.5 mutant, and this is the double homozygous mutant. And you can see it lives very short. It's small, it has ataxia, epileptic seizures, and its brain pathology is very similar to the human disease. And I'm going to show you, this is the double homozygous mutant. And you can see his pulse widespread because to balance, and you can see that keeping a balance for this mouse is impossible. So this is a very good model. Then Dr. Bonkowski also has a model. It's a zebrafish model. And zebrafish are different from mice. They are also vertebrate, so that's good. And they have conserved genes as compared to humans. That's also good. But mice are expensive. Zebrafish are inexpensive. And they allow rapid development of random mutants, which is easy. But it's also possible to make specific mutants using special technology, CRISPR-Cas. And these zebrafish model facilitates studies on disease mechanisms. And they allow rapid screening and identification of compounds. And these are two papers of Dr. Bonkowski's group on the subject. So now we know how it works. What shall we do? One is avoid provoking the ISR. And those are here. So avoid fever, avoid infections, avoid head trauma. The second point is work on the endoplasmic reticulum stress. The third point is increase EIF2B activity, either directly or indirectly by working on its phosphorylation. And the fourth point is modulate the ISR activation by working on GAT34. So avoid provoking the ISR really works. This is the proportion of surviving patients, and this is the proportion of patients walking. This is without episodes, and this is with episodes, without episodes, and with episodes. And you can see that the episodes really have a negative impact. So it's important to avoid them. And it works. I've seen vanishing white matter in the 19s when it was dominated by those episodes. And that's not true anymore. So the disease has become quieter, but the chronic decline is unchanged and patients still deteriorate. So, and I understand it's not sufficient because vanishing white matter starts at this level. The only thing we take away is this extra activation of the ISR. So that's not enough to really work on vanishing white matter. So reduce the endoplasmic reticulum stress, and that can be done by compounds like tauroursodeoxycholic acid or 4-phenylbutyrate, and we are testing them in vanishing white matter mice, and the preliminary results are not promising. And again, I understand that because it only works on the upper level, whereas vanishing white matter starts here. Then another possibility was brought up by Dr. Elroy Stein from Israel, and she found evidence that the sigma-1 receptor agonist may work, and that works at the interface of the endoplasmic reticulum and the mitochondria. So again, upstream of vanishing white matter. We are testing it in vanishing white matter mice, and preliminary results do not look promising. Increase eIF2B activity directly. That is, a compound screening has been done by a group in California, and a new drug has been found, at that time called ISRIP for ISR inhibitor, and it stabilizes eIF2B and increases its activity. We have tested this drug in vanishing white matter mice. This is the 2B5 homozygous mutant, this is the 1.5 mutant, and we started at the time that the disease had already started, and we treated them until the humane endpoint. And what we found is they did much better. These are the slips on the balance beam, so normal mice don't slip so much. Vanishing white matter mice slip a lot, and with treatment, you can see the slips go down. The speed is high in normal mice, and with treatment, it goes up. So that looks good. The motor performance becomes much better. And we also found that the brain pathology becomes better, and that the ISR activation in the brain is less. So that's really looking good. Then as soon as there's something good, a drug is developed, you can make modifications that are even better. And so multiple new drugs are either being developed or have been developed, and one is 2B-ACT, is a novel improved eIF2B activator, and it has also been tested in the same eIF2B 5 mutant mice, and also gave great amelioration. There are several other eIF2B activators in different stages of development. So this is really good news. Then another possibility was increase eIF2B activation indirectly by working on its phosphorylation level. And that can be done by two compounds, trazodone and lithium. Trazodone is an antidepressant, lithium is a mood stabilizer, and they work on the phosphorylation level. So the lithium was found by compound screening of the vanishing white matter zebrafish by the group of Dr. Bankowski. And together we tested it in vanishing white matter mice, and at high levels causing side effects in mice, we saw no beneficial effects. And we are now working also on trazodone. Then the last possibility is modulate ISR activation by working on GAD34. And Guanabens is an old FDA-approved alpha-2 adrenergic antihypertensive drug. It's introduced in the 70s and known since, and that means that you really know it's safe. And it's been tested in patients from 12 years on, and we never saw long-term adverse effects. Its most important side effect is drowsiness, but it wears off. And as I said, its ISR target is GAD34. It was already known that it worked in mice with other neurodegenerative disorders. So we tested it in vanishing white matter mice, and found that it has an ameliorating effect on the brain white matter, also on the ISR activation. So that looks good, and found that sedation is its side effect. And then we tested different doses in, this is the 1.5 mutant mouse. And this is the neuroscore. The higher it is, the worse it is. So this is the untreated mouse. So there's a rapid increase in neuroscore. This is the weekly treated mouse. And this is the daily treated mouse. So the daily treatment is best. Then slips on the balance beam. This is the normal mouse, and this is the untreated vanishing white matter mouse who slips a lot. And with weekly treatment, it becomes less, and with daily treatment, it's almost 0. And then this is the number of seconds to pass the balance beam, which is high in the untreated vanishing white matter mice and decreases with weekly and daily treatment. So that means that guanabens also looks very good. The conclusion is that the ISR offers numerous therapy targets, which is great news for the vanishing white matter fields. And what we see is that targets close to eIF2B look more promising than targets further removed. Especially promising are eIF2B activators and compounds targeting GAD34. And almost ready or ready for human trials are eIF2B activators in guanabens. eIF2B activators are novel compounds, so we need to be a bit more careful about them. And guanabens is an old, well-known drug. So as per June 1, the first trial with guanabens has been started, and we'll talk about that later today. Thank you so much, and I'll stop sharing. And then I think that the next speaker is Peter van der Ven and Pieter van Bokhoven, and they'll talk about approaches to trials for rare disorders.
Hello, everybody. My name is Pieter van Bokhoven, and today I will be talking to you about clinical trials in vanishing white matter disease. So I'm going to share my screen now, which always takes a little bit, so hold on. So here we go. So the topic of today is clinical trials in vanishing white matter disease. So unfortunately, I cannot be here today with you. So I recorded this video. And the reason is because I actually became a father myself a couple of weeks back. So I have today what is called a daddy day in the Netherlands. So I'm taking care of my son today. Luckily, one of my colleagues, Peter van der Ven, is also in the virtual meeting room today. So in case you have any questions about this presentation, Peter van der Ven will be there to answer these questions for you. And so maybe a bit of introduction about Peter and myself. So we both are advisors to the Vanishing White Matter Consortium on the design of clinical trials in Vanishing White Matter. And I will also explain you a little bit about who I am and what I do. So I work at an institute called Amsterdam Neuroscience. And at the institute, I am responsible for setting up collaborations with biotech companies and pharmaceutical companies for the development of drugs for brain diseases. And so these are mostly neurological disorders. So personally, I've been working for a very long time on Alzheimer's disease and other types of dementias, which is where my expertise is. But I have been asked by Mario van der Knaap to also work as an advisor to the consortium on and advise the consortium on how to run these clinical trials well and also efficiently. And the reason is also because nowadays more and more biotech companies are actually developing drugs for vanishing white matter, which is really great news, but also comes with challenges for clinical trials, which I will be talking about today. So maybe as an introduction, maybe some of you wonder what drug development actually is, and it's actually not that complicated. It's actually quite simple because it consists of two different phases. So you have what we call a preclinical phase, and these are really studies that take place in a lab. So these are really bench scientists, so chemists, biologists, that are trying to develop new drugs, new treatments for different types of diseases. And in the case of vanishing white matter, you might have heard of a gene and a protein called eIF2B. And over the last years, many scientists have been working to come up with what we call eIF2B activators. So these are really molecules that chemists have designed to activate this gene. Now, the great news is that these chemists have become more and more successful. So there are really new treatments that have been developed in this so-called preclinical phase in the lab, which is really great news. But now the next phase is to test if these drugs also work in patients, if they are actually efficacious. So then you come to the second phase of drug development, which is what we call the clinical phase, which involves clinical trials, where you are going to test if these new drugs actually work for treating patients. So in this case, vanishing white matter patients. So I will first give a very brief introduction in how these clinical trials work. So the golden standard of clinical trials is what we call the so-called randomized controlled trials. And the way they work is really simple. So you have a population of patients, so in this case, vanishing white matter patients, and purely by chance, this group of patients is divided into two different groups. So group one, they receive the treatment of interest. So in this case, a new drug that has been developed. And the second group, so group number two, receives a control treatment, so a placebo treatment. And the main advantage of this method is that these two groups are exactly the same because they have been generated by chance. And the only difference between these two groups is the treatment that they receive. So you almost know for sure that if there is a difference between these two groups, is that this difference is caused by the actual treatment and not by something else. So that is why this is called the golden standard. Maybe one side note. So when I say placebo treatment, it can be that this group number two receives standard of care, and that, for example, this first group receives standard of care plus a treatment. So it doesn't necessarily has to be a placebo treatment as is. So now, when you run these clinical trials, then in the end, you look for differences between these two groups. So differences in clinical score. So for example, see if patients can still move as well, or are able to walk, or are cognitively functioning well. So we look for clinical outcomes, but also compare, for example, brain images of these two groups. So to see if there is differences in brain images, such as, for example, MRI images, which I think other presenters will talk about today, if there are differences between these two groups in in the placebo group compared to the treatment group. Now, this is really the golden standard that works really, really well for many different diseases. So, for example, in my case, Alzheimer's disease, but also for cancer patients or for oncology or patients with diabetes, this works really great. But now the difficulty comes is that this randomized controlled trials is not particularly well suited for vanishing white matter patients, because this also comes with different types of challenges, which I will address right now. So these randomized controlled trials are not really well suited for all vanishing white matter patients because of a couple of reasons. So one reason is that vanishing white matter patients can be of really different ages. So you have very young patients. So these can be patients under 4 years old that are becoming ill very young, and also the disease progresses really, really fast. Now you have also a group of patients that are a little bit older in their disease onset, and also they progress much slower. So those are really two different groups of patients. Now, these randomized controlled trials, they work really well they can work really well in this older group of patients, because you can treat half with placebo and half with a drug of interest. However, these randomized controlled trials, they are not well suited for these younger patients, because these very, very young patients, which are, of course, patients under 4 years of age, they progress really fast. So it is simply unethical to treat these patients with a placebo treatment. And this is also something that has been discussed extensively in the consortium. And it is really the opinion of all the consortium members that treating these very young patients with a placebo is simply something that you don't want. And of course, I think you, as either patients or maybe a mother or a father to a patient, can really understand that you simply don't want to treat your children with a placebo treatment. So these randomized controlled trials are not well suited for these young patients. Another difficulty that we run into is that vanishing white matter, as you know, is a very rare disease. So there are not many patients available to run these clinical trials to see if these drugs are effective. So we, as a consortium, have to think of ways to run these clinical trials very efficiently, and which is also a challenge that we need to address. So the Vanishing White Matter Consortium has thought a lot about possible solutions for running clinical trials in vanishing white matter disease, sorry. And the main solution, and I think a very good solution for running trials in younger patients, is to not compare the treatment group to a placebo group, but compare these to what we call natural history data. So Mayo van der Knaap, but also many of her colleague neurologists really around the world, they have been collecting data from these very young patients and see how they progress over time. And this is data that is what we call these patients are very deeply phenotyped. So a lot of detailed data about these patients has been collected. So this is very well suited to work as a control arm and compare this data to patients that have been treated with a drug of interest. So this is, I think, a very good and elegant solution for the younger patient populations. Now, a second solution that the consortium has come up with is for the older patients. And that is something that we call platform trials. And these are different from normal randomized controlled trials, because these normal trials, in these normal trials, you compare usually just one treatment to a placebo arm. But in these platform trials, what we do is try to test multiple types of treatments. So intervention number 1 and intervention number 2, and compare these to the same placebo arm, so to the same standard of care. And the big advantage here is that you can compare multiple treatment arms to only one placebo arm. And that's a really big advantage, because much fewer patients will in the end receive a placebo treatment. And that is, of course, good for the patient. Now, another advantage with these platform trials is that they can be adapted, so you can add other treatments. So if, for example, a biotech company, a new biotech company has come up with a new type of treatment, then you can add that as an additional arm and also compare that to the same placebo group. So again, you would need much fewer placebo-treated patients. So this is, of course, a very effective way, because I think the good news is that there are more and more biotech companies that are developing drugs for vanishing white matter disease, which is really great. And these platform trials are a way to very efficiently test these new drugs. And this is, of course, because in the end, one of the main goals of the consortium is to really bring the best treatments to vanishing white matter patients, but also as efficiently as possible. That is, of course, really a challenge, but it's something that the consortium is really committed to, and platform trials can provide a solution for that, to really bring treatments to patients fast. So I want to end this presentation by, first of all, thanking you for listening. I think me personally, I'm actually quite hopeful about these new treatments that are being developed. It's really an exciting time, I think. It's really progress is really being made at these biotech companies. I think my colleague Priska Leverink will talk to you about that a little bit more extensively later today. So I want to thank you for listening. Also, maybe good for you to know that this was actually the very first time in my life that I presented to patients and their families. And because usually at scientific conferences, you present to your fellow and your colleague, your scientists or clinicians. But I think it was a really great opportunity to actually talk to and present to patients, which I think is really very, very important. And therefore, I really want to also thank the ULF Foundation for providing me this opportunity. And last but definitely not least, I really want to thank the Vanishing White Matter Consortium to give me the opportunity to think along with them about running clinical trials in vanishing white matter patients. I have really learned a lot from them, and I can assure you that you can be really happy with this consortium, because I've become to know the consortium as a group of really, really knowledgeable neurologists that are really dedicated also in bringing and developing new treatments and bringing these treatments to patients. So yeah, I think, and I hope to see you in person and in real life when that is possible again after the pandemic. Thank you very much.
Thank you so much. In the audience is Peter van der Ven, trial statistician, and I understood yesterday that he has to leave in, I think now 20 minutes. So I agreed with him that there could be questions about trial design, and he will be happy to answer them. Is that correct, Peter?
Yeah, that's correct.
Okay. So anybody with questions on trial design? Peter is specialized in as a statistician in rare diseases. So he tries. I think in the end there will be trial. There will be one-person trials, right?
Yeah, there are also. I'm also involved in N-of-1 trials where typically you only have like that's very rare diseases. That's only like 3 persons in worldwide, and then you. Well, the only thing you could do is give the treatment to the patient and then alternate with placebo within a patient. So treat the patient for some time, see how he reacts, then not treat him for some time, and then see if the disease worsens again, and do that a couple of times to see if there's an effect in a single patient. And I think we're going to the knowledge increasing, we see that many of these diseases are very heterogeneous. Not all patients respond in a similar way to treatment. So that's also a way to go. So vanishing white matter is a rare disease, but still there are diseases that are even more rare and pose even more challenges to clinical trial design. That's right. Yeah.
So thank you, Peter. In the audience, is there anybody who wants to ask a question about trial design? Or want to discuss something?
I had a question. And this is just kind of out there, but I'm wondering, in the trial designs, are you all controlling for each patient's number 1 through 5 abnormalities? And I ask that because there seems to be some variation in terms of just the outcomes of the patient's normal life histories. So I'm wondering if that's controlled for at the beginning of the trial, and if you anticipate differences between the numbers 1 through 5 in how the drugs might treat them, or if it would be the same for all of them. And thank you.
That is a good question. Yeah, typically we try and foresee these things when we design a trial. You don't want all patients in one group. For instance, patients with worse prognosis, all to be treated with placebo, and the other one, the better patients with the drug, because then you will get a bias in the estimate. So what we typically do is define subgroups beforehand, and then do the randomization, the tossing of the coin to see who gets placebo and who gets the experimental treatment within those subgroups. So here you would do it separately within the class 1, group 1, group 2 until group 5. So that also helps you to get to even have comparable groups, even though your numbers are quite small, because you equally divide within subgroups over the two treatments. A more difficult challenge is when the disease is only effective in a subgroup of patients, or accepted to be, because then you really have to look into the subgroups, which are typically quite small, and it's quite difficult to see if a treatment is really effective or not. So especially in rare diseases, that poses quite a challenge. So typically we first look in the whole population, so the combined group, to see if there's an overall effect. And after that, we, for instance, visually plot the treatment effects for the different subgroups to see if there are differences between them. And if there's large differences between them, then that's a reason to further look into that, to see if there's a mechanism that could explain the differences, and that could be used to see if a drug would be recommended for the whole population or only for a sub population of the patient. So.
Other questions? Perhaps I may ask a question, Peter, because you just said it. If you test a drug for a specific age group or for a specific subgroup, does that mean that the registration is also limited to that group, or that you may generalize the effects?
Well, that depends. Typically, the registration is quite restrictive, so only in the group in which it's tested, or you should really have a good motivation, a biological mechanism to support a wider registration. But that can be quite challenging. Normally, it's only registration can only be done for the subgroup that you for the subpopulation in which you perform the trials. Yeah.
So we have still a lot of challenges. Any other questions? I think that there are two situations that would bother me. One is there is an effect, but we missed it because our trial design is not good enough to show it. But in fact, the drug would work if we would have the trial would be big enough or well designed enough, or there will be an effect. Whereas in fact the drug doesn't work. So a false outcome.
Yeah, and especially in smaller trials, in small populations, it's very difficult to tell whether you, well, it's much easier to make a wrong decision, especially when you also want to the power, the effects that you can show with a specific number of patients is quite low because of the rarity of the disease. So you can only show very large effects in the small trials, which may not be the only effects of interest, but probably you will also want to show moderate effects. But that can be challenging with the smaller numbers. Of course, for registration, the authorities are a bit more flexible when it comes to the data that you provide for registration. They normally look not only on the significance of whether the trial is significant or not, but they also look at the effect size and do you see the effect on multiple outcome measures, not only on one outcome measure. Is the effect consistent over different subgroups? Is there a possible biological mechanism that explains the efficacy of the drug? So these are all things that could help in getting faster approval of drugs in rare diseases. So that's I hope that's at least shed some light and at least some drugs will become available soon for vanishing white matter.
I think if there are no other questions, that we thank you, Peter, and it's wonderful that
Dr. van der Werf, I have a question. I received this is Dana. I received a question, a message saying, how long will it be before Guanabans will be available for compassionate use, and what are the steps to get it as a compassionate use?
Shall we discuss that this afternoon?
Okay.
Because this afternoon there will be a session on the Guanabans trial, so okay. I think that's important.
Okay.
Unless, Peter, you have to say anything special about compassionate use?
I think you also know that, you know that better than me probably as a statistician, that so I also think I would not know the answer to this question, and you probably have better ideas. So.
Well, as a consortium, we talked about compassionate use, so we'll talk a little bit about that this afternoon if you wish. Yeah. And I would say, Peter, thank you so much. I'm very grateful that you are willing to help the consortium sometimes with our questions, and also are helping, with our dealings with pharmaceutical companies if we have questions. So that's just wonderful. Thank you so much.
Okay, welcome.
Thank you. And then I think I give the floor to Priska.
Yes.
And share her PowerPoint.
Okay. Hopefully you can see my screen. And it should show as a slideshow now. Is that correct? Okay. So to follow up on Peter's presentation, I will speak about the interface between industry and the Vanishing White Matter Consortium in a little bit more detail, especially explaining how we work together and who we are working with currently. First, I will introduce myself. I think most of you will not know me yet. So I have a background in vanishing white matter research. So I did 5 years of preclinical research in the group of Mario van der Knaap, where I mostly worked on preclinical models using stem cells and the mouse models of vanishing white matter to try to understand disease a little bit better. We published a few papers on the work and also tried to work towards treatment options. Then in 2018, I started the team of Peter van Bokhoven, who just gave the previous talk in the Industry Alliance Office of Amsterdam UMC as a business developer. Here in my portfolio, I have mostly the preclinical research collaborations with industry across various indications, but also the leukodystrophy clinical trials together with Dr. Mario van der Knaap and also Dr. Nicole Wolf. And as a side project, I work as a business developer for the Vanishing White Matter Consortium, and I do with a lot of joy and pleasure. So first of all, you may wonder why industry collaborations, why would you need a consortium, why an industry alliance office, why does it have to be so difficult? So as the previous speakers already indicated, several companies are now developing treatments for vanishing white matter. They need to be tested, but that sort of raises more questions than answers at this stage. And as Peter explained, because vanishing white matter is a relatively rare disease that also has a complex nature, clinical trial design is difficult. This is related to the different ages of onset that several of the patients may have, also different progression rates and different clinical outcomes that may be experienced as most clinically harmful or meaningful if they would improve. And of course, these are all items that different groups are thinking about. But we understood from the Industry Alliance Office experience that industry collaborations between academia and biotech and pharmaceutical partners, they do not always speak the same language. They do not always have the same goals or ideas in mind. And it can be sometimes challenging to interact because you're coming from a different background sometimes. And therefore, it was considered helpful to have a sort of intermediate office to assist with those efforts. Also simply because these interactions require a lot of time, and quite often all our clinicians are very busy seeing patients and doing their own research. So why do we need a consortium for industry collaboration? Well, if you look at the different partners or different parties involved, you can see that there's vanishing white matter patients and the biotech pharma industry and the Vanishing Consortium. They all have the same goal: vanishing white matter treatments. And of course, the aim for the patients is to have access to treatments. What they need for that is new drugs to be developed and new trials to be designed. And what they can provide is extremely important, which is patient experience. We need to understand your side of the story to understand how we can help you. And you can provide participation in such questionnaires, but also in the clinical trials. On the other hand, on the other side, you have the biotech and pharma industry. What they can provide is drugs that need to be tested. And what they actually need is guidance during the drug development phase. So they are expert in the drug that they are developing, but they are not necessarily always an expert in the disease that they're trying to treat, simply because it's such a niche environment. And the second thing that they need, of course, is patient for those testing efforts. And therefore, we decided that the Vanishing White Matter Consortium can sort of form the missing link in this process and really be interacting with all partners so that they can find each other, and all together we can come to well-designed clinical trials, testing drugs for the Vanishing White Matter patients. So what is it exactly that the consortium can provide to the industry? Well, they are experts about the disease. And they are that because they know you. They've been seeing patients for decades, and they have the overview. So they know the demographics, for example, the different ages of onsets, how rare it is, the different mutations, how large the current patient population is. They understand the natural disease course of vanishing white matter, which, as Peter explained, can be very important also in comparison for clinical effect. You need to know what the sort of the baseline situation is in order to be able to recognize any improvement that these treatments may give. And very important, they're also, many of them are basic and clinical scientists. So in these academic studies, they generate more knowledge about the disease mechanisms that leads again to drug targets. They develop all sorts of preclinical models that may be very important also for the testing of industry compounds. And they can provide guidance and advice during the clinical trial design. For example, in relation to the type of study, as we just discussed, what is the control group? Would it be a platform trial? They can advise on the different biomarkers and clinical skills as an outcome. So how can you measure effect in different groups? For example, perhaps in patients with a younger onset, you might want to look at motor phenotypes more, but perhaps in patients with a later onset, there are cognitive skills that you want to evaluate. So they can provide advice on that, and they're very willing to advise on that. So they're very eager to interact with these industry partners to make sure that all this knowledge is sort of transferred and being used in practice. And last but not least, in relation to the previous question as well, of course, you can have wonderful clinical trials with wonderful treatments, but in the end, they need to be approved in order to find their way to the patients. So we need to interact with the FDA in America and EMA in Europe to make sure that we follow all the guidelines and know what is required to have the drugs approved, which is eventually how we can get it to the patients. So as I indicated, the interaction between academia and industry, it's easiest if that is organized in a structured way. Often a lot of academic departments may not know exactly what the other one is doing. So it's nice to have that integrated. So for Amsterdam Neuroscience, we have an industry alliance office. Arjen Bressard is our director. And we have a dedicated team of business developers. So that will be Peter and me in this context. And what we do is we actively seek for partners in our areas of interest. So we go to scientific conferences where we try to set up appointments with industry partners. We go to so-called partnering meetings that are biotech meetings where all different companies attend, where you can really meet new people and learn more about what is happening in industry. And we do the communication with the industry partners. And next to that, I think one of the parts that is most underestimated how much work it is all the legal and financial administration. And I'm mostly talking about legal, because as soon as you start working with industry, you need to have all sorts of agreements that you put into contracts. For example, what information is confidential and what information can be shared with the public. You need to trust each other and also have all the right paperwork in place in order to facilitate these conversations. And we have a legal and financial team that is fully dedicated to do that. So they also assist with the consortium interactions. And when I say financial administration, I of course mentioned that we are a non-profit. So this is all, any research money coming in is going directly to research purposes again. So we are very proud to announce that we do have industry partners. We've been interacting with industry since the beginning of the consortium. Unfortunately, I'm unable to disclose them all. Some of them indicated that they might still find it too early in their drug development efforts, or they felt they still couldn't provide the answers that many of the questions might give at this stage. But we're very happy to announce that we have both preclinical and clinical collaborations with different partners. The first one I will highlight is Celix. Celix is a so-called service provider company, and they specialize in neuroscience mouse studies. So as we heard earlier today, at Amsterdam UMC, different vanishing white matter mouse models have been developed, and they have the same genetic mutations as are present in some of the vanishing white matter patients. And they develop a clinical disease that is very comparable to the human disease. So you can see that they have a very, what we call genotype-phenotype correlation. What they also have is very comparable pathology. If you look at the brains of these mice, the brains and the spinal cords, and these animals are very valuable for early drug testing. So you always want drugs to be tested first in a relevant mouse model of the disease before you move to human studies, of course, because you want to know if there's any effect expected. And that's why Amsterdam UMC made these mice available for every industry partner that wants to test the drugs in the mice. So while we do not have the capacity in Amsterdam to do that in our own labs, that's why we partner with the specialized company Celix. So we have now transferred the mice to Celix, where they are available for all industry collaborations who want to test anything in the eIF2B mouse models. So I would all encourage you, if you are interested in that, to follow this link or follow on our Vanishing White Matter Consortium website. The second company that I can announce today is Denali Therapeutics. We're very proud to have you as a partner. I'm very proud that we can announce it. Denali is developing eIF2B activator. So I think the mechanism of action has been discussed earlier, showing how you can activate eIF2B. Their compound is called DNL343. It is a small molecule and it can penetrate the brain, which is a very good, important aspect of this small molecule. It is designed to rescue eIF2B function, and it is currently in the early stages of clinical development. So the target indications are both ALS and vanishing white matter disease. And Denali has very much encouraged engagement with the vanishing white matter community already early in their preclinical developments. Please have a look at their website if you would like to know more about this compound. And we're very, very grateful that we can work with them together. We highly appreciate our collaboration and are very much looking forward to continuing our developments together. So as we already mentioned this morning, very recent, actually this week, our Vanishing White Matter Consortium website went live. So for any information, you can have a look here, and I would welcome everybody to take a look. So you can find more information about the consortium members and our mission, some background information about vanishing white matter disease. We have a page where we announce all clinical trials. So currently this is the Guanabens trial. We have several updates. We have news items, and one of our news items was, of course, that we are presenting here today. We also have some relevant literature, some scientific publications about vanishing white matter disease. And we are very proud that we have several partners that we have already listed on our website, including Denali Therapeutics and Celix that we mentioned today. but also the family foundations and associations. And you can find our contact information here as well. So last of all, I really want to thank you for your attention during my presentation. And a very big thank you to the United Leukodystrophy Foundation and the consortium. It's a real pleasure working together with you, and I'm always looking forward to our video meetings. If anyone in the audience has questions, I'll be around later during the general discussion, but also please feel free to drop me an email about industry collaborations, or perhaps you know a partner or you have an idea for a compound. Yeah, please just drop me an email or have a look on our consortium website. And then thank you for your attention.
Thank you so much, Priska, for your wonderful talk and your presentation of the Industry Alliance Office and your work. That was wonderful. Thank you so much. And then we move on to Dr. Geneviève Bernard, who will talk about the interface between medicine, patients, and families. Geneviève.
Hi. Okay, I'm just trying to share my screen. Give me. Can you hear me well?
Yeah.
Okay. Okay. Can you see my screen?
Yeah.
Yes. Okay. So, hi. I'm very happy to be here today. I'll present shortly on the interface between medicine and families. I have no relevant disclosure for this presentation. I'm involved in several family foundations. I'm the chair of the Medical Scientific Advisory Board at the ULF, and I'm involved on different clinical trials. And I also recently got an unrestricted educational grant from Takeda. So the opinion of the patients and their families is crucial in developing the clinical trials. It is important for us to hear about what's important for you to determine what the most relevant clinical outcomes will be on the trials. Because what we think as physicians as a desirable outcome from a treatment may be different than what you think as parents or as patients. For example, we may think as clinicians or scientists that the most desirable outcome would be to preserve ambulation. So, but it may well be that for the patients and families, the most important outcome would be to preserve communication. So for example, improvement in slurred speech. So the patient voices are very important in the design of the clinical trials. Oh, sorry, you don't see I didn't change any slides. I'm so sorry. You don't see my, 1 second. You just see, okay, sorry about that. So this was my slide about what you just said. I didn't realize I switched, I changed my slide, but it didn't work. Okay, now I'm going to do it. I have to do it twice. I apologize for this. Okay. So in most clinical trials, they're a natural history study. There are what we call parents and patients derived outcomes. These are numerous types of outcomes measure that we use. They could be qualitative studies. They could be quality of life questionnaires, involvement, and the implication on the parents' daily life, such as parental stress, and there are others as well. So we're just going to go through some of them. So qualitative studies are basically patients or family interviews. They could be very structured. They could be completely unstructured or semi-structured. So what my lab is mainly doing is semi-structured interview. And so the objective is to learn about the patients and the family's experience. And it can give us insight about what to further study and what would be the important outcome to hope for with a new treatment. The interviews are typically recorded and they're transcribed, and the analysis is done with a special software such as NVivo 12 and then you identify key concepts that you can further study. And then and potentially further study in a more with other types of questionnaires. So the quality of life is very important for these studies, because most importantly, we want to improve the patients and their families' life when we develop treatments or when we do supportive therapy as well. So one example of quality of life questionnaires are the PedsQL. And so I've put you just a screenshot of one of example of them, but there are several different quality of life questionnaires looking at different types of involvement. There's so this one is a general well-being scale. So as you can see, it is a questionnaire like in the last month. How much does this sound like your child? It feels happy, good about themselves, etc., etc. And then you click on like never, almost, never, sometimes, often, and almost always. And these are scored and give a score for the specific aspect of the patient's life. There are other scales such as the multi-dimensional scales for physical, emotional, social, and school functioning. There's also a fatigue questionnaire and numerous others. So my lab did a study on quality of life in patients with leukodystrophies in general. So it was a pilot study. So we looked at 59 patients with different types of leukodystrophies or genetic leukoencephalopathies. And we did the pediatric quality of life questionnaire, different types of them. And then we also did standard clinical assessment or standard clinical questionnaire. And what we were able to demonstrate in this study was that, not surprisingly, patients with more severe clinical features had lower quality of life score. And the lower quality of life scores were seen in patients with drooling, a gastrostomy tube, dystonia, and use of a wheelchair. So amongst these, the drooling is something we can treat. So it is important to know that it does have an impact on the patient's quality of life because it's treatable. So we can have an impact on the disease course and the patient's daily life. The dystonia is also something that is treatable. So these studies are important example of things that we can target as physicians that are important for the patients and their families. And I just want to mention that the person who did this study in my lab is Amitis Merci. Okay, so for parental stress, two people in my lab worked on this, Aaron Spar and Emily Dermer. And it is important to look at parental stress because it allows us, because it has an important impact on how the parents are doing, but also how they are able to care for their children. So increased parental stress has been associated with parental depression and maladaptive parenting practices and potential mismanagement of the patient's care. So we looked at, we had 55 parents from 36 families, and we used the Parenting Stress Index 4th edition. So what we found is, not surprisingly, the mothers and fathers of patients with leukodystrophies have more stress than the regular population. It was a small study, so to have statistically significant results, we would need a larger study. But what we were able to identify is that for the mothers, the behavioral problems of the child are associated with more stress. And the more severe, surprisingly, the more severe the gross motor impairment was, the less stress the mother had. And so one of the hypotheses that we brought forward for this is that by the time, in most leukodystrophies, by the time the child is wheelchair bound, the parents had time to start their grieving process. But I think that tells us a lot about how much we can, as physicians and healthcare workers, help the families through these difficult moments, and hope that that we can help them with their grieving process as the child is losing milestones. Of course, larger studies are needed to identify modifying factors that we could improve, so that we can improve the parents' quality of life and decrease their stress. So the clinical research studies in my lab are funded by the estate of Daphne Dale Thompson and the NUHC Department of Medicine and the Montreal Children's Foundation, and my salary support is from CHR and Fonds de Recherche en Santé du Québec. And this is my clinical team. Anitis worked on the quality of life. Emily and Aaron worked on stress, parental stress. Luan and Simon are my clinical research assistant. Hilia is a new master's student in the lab. She works on natural history studies. And Laura is a summer student soon to start her master's degree on parental stress. Aline, Olivier are both medical students in the lab and are working this summer on natural history study. And Anne-Michelle is a secondary 5 student who wanted to have experience in the lab looking at parental stress and quality of life of patients and families. Thank you very much for your attention. Please, I'll be happy to answer any questions later on.
Well, thank you so much, Geneviève. That was a beautiful overview. And I think also a great connection to the next talk, in which Donna Squirrett will give a talk about the perspective of Vanishing White Matter families. Donna, do you think you can share your screen?
Yes, I'm going to start sharing. Hold on 1 second, please. Okay. Now, can you see my presentation?
Yes, we can see you, and we can see your presentation, and we can hear you.
Okay, good. So welcome again to United Leukodystrophy Family Foundation virtual conference. And this session is the perspective of VWM families. And first, I would like to thank the following families that gave me their perspective that you will see in the slides. Jake and Paul, Kelly, Lexi, Kylie, Angel, Isabella, Sam, Reed, Jax, Henrik Neto, and Edison Rose. As you see, vanishing white matter, as we say, it's rare, but it's everywhere. And we are connected and bonded all around the world. So for those of you that don't know me, my name is Dana Squirrett. I'm part of United Leukodystrophy Foundation since December of 2019. I'm the face behind the Find a Cure for VWM. And also I'm administrating several other Facebook pages and our private VWM Family Forum group. I am very grateful to United Leukodystrophy Foundation for organizing these meetings. And ever since my niece was diagnosed in 2009, my sister has been attending these conferences. And United Leukodystrophy Foundation, we are grateful that they provide that they make these conferences, and we can talk to the world's best doctors and researchers. And as we say, alone we are rare, but together we are strong. So how is it to see that something is wrong with your child and not knowing what it is? Some say ignorance is a bliss. For some, it's a years of testings and test after test and blood works and different x-rays. For some, it's a quick diagnosis because their child fell down, they are rushed to the hospital, they do MRI, and that's how they found. For some, it took 28 years. They knew something was wrong with their child at the birth, but nobody knew what was. And it was years of looking and years of looking different research and attending conferences. And then again at ULF, they were connected with the doctor, with the NIH, and that's how they were diagnosed. And for some, it starts with seizures, and it leads to a quick VWM diagnosis. So how is it to hear the diagnosis? Well, for some, when they hear the diagnosis, they are confused. The word leukodystrophy is something that they've never heard, and they don't even know how to spell it, and then to learn that there's so many different kinds. At first, the doctors think, oh, maybe it's MLD, maybe it's Krabbe, maybe it's LAD, and then they learn it's vanishing white matter. So it's very terrible to hear the diagnosis. Then you read what the Google says, and it's even more. Then the doctors are telling you it's terminal. Just go home and make most of it the time. When you hear the diagnosis, the world just stops for you that day. They are devastated, but at the same time, some do feel relief because finally they know the name of the disease and they know what to do. They know how to fight it. But at the same time, they are helpless, angry, and guilty that they passed the genes onto their child. They are powerless. They also turn into God, question God why, but at the same time, they try to prepare spiritual themselves and the child, and they go through a grieving process. So now, how is it to live with the VWM for patients and family? Again, this disease is terrible. It's the hardest thing for the family to watch their child go backwards, to stop walking, talking, and feeding tubes. And also to keep the child healthy. At first, they think that they need to keep their child in bubble. It's like the child is like a porcelain glass, because no head bumps, no fevers. But at the same time too, they're saying that they need to have their child to enjoy their life and to do as much as they can and be happy as they can. So it's also very exhausting. The parents have to watch the child struggle and go through the pain, and there is nothing sometimes that they can do. They're not only losing a child, but the parents also end up losing the family, friends, and then loved ones, because it's too harsh for them to see the reality. Sometimes even the marriage falls apart. So basically, this is like a chronic sorrow. Yes, they try to enjoy the life where you can, and parents become the experts. They are the ones that are telling the doctors how they should treat their VWM child, what they should do, because most doctors never dealt with VWM patients. It affects siblings. Siblings, they need to adapt and become more independent because the parents are more involved and very busy taking care of the VWM child. So the siblings learns to sometimes at an earlier age to make their own lunch, to be a nurse, to know how to stop the beeping noises on the equipment. So the siblings also become a nurse assistant. Now, how is it to hear that there is no treatment? Life changes for your goals, your dreams, and priorities take different turns. You realize your child will probably not go to prom. Your child will not drive. All the dreams that the parents have disappear but they learn to cherish every moment because, as they say, we only have this moment that's sparkling like a star and melting like a snowflake. You say it's unfair, and they hear that there's no treatment, but at the same time, they do need to realize, or the doctors maybe need to be a little bit more specific in saying, yes, there is treatment for symptoms. There's so many things that parents can do to help with the child symptoms. And then you also become grateful for little things. There is no time for drama. And also you do realize that you have hope. You have hope, and you believe in researchers, and doctors. And saving Chloe's XB campaign was something that sparked a drive amongst VWM families and communities. And also you become experts in Google Alerts. And thanks to social media, we are able to connect with families from around the world because, as I say, VWM has a face all around the world. And everyone smiles in the same language. So the VWM, even though we don't speak all the different languages, but again, the kids smile in the same language. And the Google Translator is the best thing ever for us. We communicate with families in Brazil, Spain, just name it. Whoever doesn't speak English, Google Translate is our friend. We read every publication and we learn medical jargon because that's our hope. And how is it to know that therapeutic treatment is being developed, but all development takes so much time? It's frustrating for parents because for every parent, they know that the doctors and researchers are doing as best and as fast as they can, but that's not fast enough. Time is running against. We already lost too many children while waiting. And some just learn to accept the prognosis that there will be no cure for them in time to save their child. But they're still happy with all the developments that in the future, there will be no VWM or no child will have to suffer like theirs. Parents are very excited and hopeful about the development. They're having a hard time waiting, but they're happy that there is movement. And they cannot wait to be a part of the clinical trial. So again, as the VWM families all around the world, we want to thank everyone that's involved with the research, all the doctors, all the researchers. We want to thank Amsterdam UMC, VKS for creating the beautiful poster that explains how the Gwenabin's trial is, Ella Foundation, VWM Foundation, and Vanishing White Matter, VWM Family Foundation, and Vanishing White Matter Foundation, and obviously the United Leukodystrophy Foundation, the most for organizing these meetings and bringing us all together. Thank you.
Thank you so much, Donna. It's heartbreaking. Yeah, but it's also motivating. It's also motivating us to continue to work and to continue for the children that are now here and to continue, and I should say all patients, because it's also adults, and to continue to work for the patients of the future. Yeah, I very much hope that patients, families, doctors, companies, that we are in this together and that we are all fighting for the same cause. and take all the steps that are needed to arrive at a place where we want to be, that there's treatment for all vanishing white matter patients worldwide. Thank you very much for your talk, Donna. That really touches the heart. I think it's a good moment that we take a break, and we'll be back in a half an hour sharp. I'm proud that we stayed, all of us stayed in time. We actually 5 minutes ahead of time.
Yep.
So thank you so much. And we'll be back in half an hour with the next number of talks.
Yep. Yeah, and I'm glad we didn't lose the power. You know, I already lost power twice. I was getting very nervous that I will not be able to talk.
Well, we had some misfortunes, like Dr. Bolkowski had no internet, so he had to sit in the car in order to talk and to have Wi-Fi. And Priska saved us from the talk of Peter. You had power breakdowns, but we made it. It looked smooth.
Yeah.
And I would say we'll see you back in half an hour. And I would like to say to the ULF, there are, I think, several recorded talks in the next session. So could you please make them ready so that they can be shared, because I don't have them. Okay.
They will be ready.
Thank you.
Okay, wonderful. Thank you so much.
Thank
and
you.
See you in half an hour.
All right. Thank you.
So I would like to announce the next speaker, which is Dr. Adeline van der Ver from CHOP. And she will talk about inventory of the burden of disease with Eike Gutierrez as an example.
So first of all, I'd like to thank the ULF for allowing us to have this session for the consortium, and also thank Mario and the consortium for asking me to speak on HES. I think it's important to learn from different diseases, and different disorders are all at different stages and phases of trial development. And so it's lovely to be able to speak a little bit about Aicardi-Goutieres syndrome. I also want you to know that this work is primarily the work of a team at my institution at CHOP, including a very particular Francesco Cavazzi, who's a child neurologist from Italy, who's working with us, as well as a team actually of neonatologists who've done a lot of work on patient-related outcomes in children who have neurologic problems, Ashley Martin, Dr. Demaro, and Dr. Lorch, as well as another neurologist on our team, Dr. Adang. So I think it's also important to know that, within the medical literature, there's a lot of work on a concept called burden of disease. And we've heard a little bit about some of this type of work already from Dr. Bernard around her work in 4-H. But there are a number of very thoughtful people who are working on ways to quantify, right, how difficult it is to live with these conditions. And I think we heard from our family speaker earlier exactly how difficult this can be. And it may sound sort of weird to try to quantify it and measure it, but these things become important when you're thinking about clinical trial readiness and understanding what the impact of a treatment will be. And it becomes important in thinking about the impact of a treatment on the well-being of the affected person, but it may also become important as we work to justify to things like insurance companies who have to pay for the medications, and governments who have to decide whether or not the medications will be covered by national health plans, right? It may become also important to be able to have metrics to justify that if we can change the disease and change, for example, the financial hardship for parents, their ability to work and keep their jobs, right? In the face of these disorders, these things become very important to the ultimate ability of clinicians to deploy these therapies. And in particular, sort of in the short term, pharmaceutical companies really want to understand what symptoms are the most important to families, so they can target those symptoms in the tests that they run to see if drugs or treatments actually corrects the symptoms. And then the national agencies that approve drugs for use in rare disease, at this point, really, they won't do that unless they know that a new drug or treatment actually changes things that are important to families. And I think it's also important, I think as physicians and scientists, I think in years past, we naively thought that, we know our patients well, we see them often, we talk about them, all the time about the impact of their disease on their health and well-being. And I think for a long time, doctors and scientists thought they really knew what was important to families. And I think more recent research has really demonstrated that that's not always the case, and that there may be symptoms that we don't even think about or consider that are actually primarily important. And so overall, these approaches really impact choices of what's something special called outcome measures. And outcome measures are things that show us, allow us to measure how a disease is impacting a particular patient, and in particular in the context of a clinical trial, right, allow us to measure that in a very precise and scientific way. So there are different ways to measure burden of disease, and I want to sort of provide some framework. And again, Dr. Bernard already spoke to this to some degree. And there's sort of two opposite poles, and I thought it'd be helpful to talk a little bit about this so that you can understand the type of tools that are being used in some of these assessments. On one extreme, there's a complete open interview where you have somebody who's trained, like a psychologist or a clinician, who asks families just, how do you feel? Right? And then on the opposite end, you can have very specific standardized questionnaires that have typically been developed, for other disorders than leukodystrophies, things like cerebral palsy or other types of neurologic injury, and then ask the family to respond to pre-scripted questions in those types of questionnaires. And there are advantages and disadvantages to both systems. And this is a vast oversimplification because, as Dr. Bernard already explained, and as Dr. Kreidel-Workman will also briefly explain, in many ways, the best studies are ones where we combine these type of approaches. But the advantages of a completely open interview is that the families and the patients direct the themes. They can say, because the questions are asked in an open-ended fashion, they can explain what is important, and it's not biased by what scientists or clinicians might expect. The downside is that, as you can imagine, trying to capture the essence of a conversation that occurs between two people is much harder and might seem less quantifiable, and then less easy to describe and to capture in a clinical trial plan. The very standardized questionnaires, their advantages are that they're very easy to quantify. You can say, how many patients say yes to a specific question, and also that these same tools might be able to be used, therefore, in a clinical trial. But the downside is that the things that are most important to families may not be covered at all, and there may be a significant bias based on what questions are asked around what scientists and clinicians expect the important symptoms to be. And then the final thing is that just because a tool worked well in a disease like cerebral palsy, it doesn't necessarily mean it'll work well in a disease like leukodystrophy. So I wanted to speak just in brief about our experience using one of those types of approaches, the very open-ended questionnaire, in a disease called Aicardi-Gouttières syndrome. And Aicardi-Gouttières syndrome is different than vanishing white matter disease because most of the patients actually present very early on. There are now mutations in 9 genes total, but those were the last 2 were published very recently. And so the work we've done recently has only encompassed patients with the first 7 described mutations. And the important thing in this disease is that much like vanishing white matter disease, there really aren't great treatments yet, and the children can be normal for a period of time and then have quite significant decline. And so we wanted to create an interview that would help us do that first step of, in an open-ended way, understanding what was most important to families without overlaying our impressions or bias around what we thought was important about the disease. And so you can see from the interview guide on the right, that the questions are very what's called open-ended, right? And we had a very specific script, right? you know, questions like, talk to me about your child's story. How would you describe the impact of this disease on your child? And then we were allowed to use some what's called probes, like if the family sort of didn't know where to start, we were allowed to use some keywords, but otherwise really we were really supposed to provide very little guidance around how the families were supposed to answer the questions. And these interviews were recorded and transcribed, right? And then after they were recorded and transcribed, right? And here's the rest of the questions, so you can see sort of how open-ended things were, right? We went through and looked at the data. And at the end of the day, you know, we did interviews with 45 different parents. You know, some of them were couples that were both parents of the same child, right? And we, you know, had some background information about how severely affected an individual patient was and whether or not they were already in a clinical trial, right? And also what gene type they had within the disorder. And just like Dr. Bernard explained, you know, there are now programs that are very standardized and can actually sort of use natural language processing from documented text, right, that allow you to find common themes, right, and allow you to do some degree of analysis on what's otherwise just a conversation between people. And the families who participated in this, of course, knew that their interviews were being recorded, knew that we would write them down, and knew that they would be analyzed in this way. And, you know, we then were able to come out with some important themes, right? And, you know, some things we expected, right? You know, we expected that the families would find it, you know, very important overall how their child was doing neurologically. And we found it, you know, expected that the communication and motor abilities of the child was felt to be very important for the family. It was helpful, though, to have confirmation of that from the families, because now when we go to the agencies that approve clinical trials, we can say, we're going to measure how a child's motor function or how a child's communication function evolves over time while being on medication. And we know from this data that that is something that's important to families. And so if we can show that we make that better within a clinical trial, you know, we can show that we're making the child better from the perspective of the family. You know, other things that were also expected and that you know, our family speaker shared earlier is just the immense emotional, financial, and relationship impact of the disease, right? And we were also able to show how much hope the families have over time for improvements in the future. I think that one thing that we didn't expect was that almost all the patients, 27 out of 33, really spoke about how one of the major problems that they had in this disease was how long it took to get a diagnosis. So, you know, for AGS, different than vanishing white matter disease, where Dr. Bonkowski explained that the MRI is so characteristic that, you know, the radiologist will call you on the phone if you're the provider who ordered the MRI to say, hey, this MRI is very problematic and here are the things that make me think it might be vanishing white matter disease. With AGS, the symptoms are much more what's called non-specific, which means not specific for one particular disease. And so there's often quite a delay. And so this in a specific diagnosis, and this came up as a major source of stressors for families, which we weren't expecting to be so pervasive, because as doctors, we like to think we do a good job diagnosing patients, but clearly the timeline and the way the diagnosis was delivered to the majority of these families was perceived as a major source of stress. And you can see the dot between the open, I don't know if you can see my cursor, the open circle here and the closed circle here shows you how long it takes for some of these families to get a diagnosis. And that information we will be able to now take with us, you know, in separate work to advocate for better diagnostic approaches like newborn screening and things like that to try to minimize the impact of this on families. And then, you know, I think, you know, we also were able to look a lot at things that helped that made the families feel like they were supported during their diagnosis. And this also gives us the opportunity as clinicians to think about how we can do a better job of supporting the families and how we can better support their emotional needs at the time of diagnosis. So in next steps for us, and you're going to see some of this, as I said, in the next talk on MLD, in next steps for us, we're going to now, based on this information and knowing what's important, we're going to be able to choose some of those standardized tools that have been developed for other disorders, and we're going to try them out and see if we can capture through a standardized tools those impressions that the families had when talking to us verbally in a conversation style. And so we're going to try different quality of life measures, as Dr. Bernard is also for 4-H and has Dr. Kringelborg-Mann is for MLD, and sort of show how well those capture the burden of disease in AGS. And, we also are able now to justify the fact that things that measure the function of children with AGS, as far as their motor skills or as far as their speech, are things that are going to be important to families if we can show a change in this. And we can also work to see if in those patients who have a better level of function for motor skills and communication, their quality of life is also impacted, because then we'll be able to tell the drug companies or the federal groups that make the laws about which medications are approved, be able to show, right, that if we're able to improve motor skills and communication, which is something that's important to families, we will also be able to, most likely to impact the quality of life of these families. And so we hope that together these approaches will provide companies with the tools that they need to design clinical trials. So in a conclusion, this type of work in burden of disease that now we need to do, that we've been working on AGS and other people have been working on in MLD and in 4-H, and that needs to be done in 4-H, in Vanishing White Matter, sorry, too many diseases in Vanishing White Matter, is a major important project that we can work on together, the scientists and clinicians, as well as the disease community, to really best understand and prepare for ongoing and future clinical trials. And that's really all I have. I'm going to stop sharing my screen, and happy to hand things back over to Mario. And I will unfortunately not be able to stay for the question and answer session, because I have to go give a different session in a couple minutes, and so I'll miss the wrap up. But it's been a pleasure attending the meeting this morning, and I'm very happy and honored to work with the consortium on this important project.
Thank you so much, Adelina. And I think you have still some minutes, so we can do the same as with Peter, who had to leave. If there's somebody with a question for you, there will be some time. Yeah.
Happy to take questions if that's helpful.
Yeah, one thing, if I may say so, that you stressed is very important to me. That's making progress is also a collaboration between doctors and families. We also need their help. So they may feel they need us to work and do our job as fast as possible, but they also need to collaborate with us on our projects so that we can make progress.
Yeah. No, these things are most definitely, in the best of sense, a team effort, right? Because both in preparation for clinical trials and then in doing clinical trials, it really is a team effort with the families and the disease community to make sure that as those trials are prepared and done, they are done in the best way possible for the disease.
Yeah. And that's what we are aiming for. And I think that's also different from in the past. That we are much more aware that families and patients need to have a say in, what's important and what's not so important. Yeah. So anybody with a question? Okay, thank you so much, Adelina. It was a pleasure to see you, and hopefully next year I'll see you for real.
Yes, we're looking forward to meetings in person.
Yeah. And I'll see you in the meantime, I think, many times.
Thank you.
Thank you so much.
And thank you to Keely and the organizers. Bye.
Then we move to Dr. Ingeborg Krekelo from Germany, who will speak on her experience with an inventory of a burden of disease and then in metachromatic leukodystrophy. Ingeborg.
Thank you very much, Mario. I apologize that I pre-recorded my talk because I was not very sure that I have to tell you I'm in the south of Brittany in France, in a complicated story behind that. And I do Keely, and I hope that you'll get it now presented.
Okay, thank you so much. Thank you. And it's lovely that you are present in person as well. But your Wi-Fi is a little bit shaky. So it's good that so your plan is to present now the pre-recorded version, right?
Yeah, and I send it to Keely, and I hope that she can bring it in.
She promised.
Yes, we have it ready to play if you would like me to start it.
Yes, please. Thank you very much.
Ladies and gentlemen, thank you very much for inviting me to this year's online OLF meeting. My topic is also the burden of disease, but it will be on a different leukodystrophy and with a different methodology. So I hope to be able to give you some additional aspects. As a pediatric neurologist caring for children with rare neurological diseases, we want to know what is the cause, what are the early signs, how is the disease cause, and is there a treatment, and especially what is the effect of this treatment. And in order to better understand this, we collect data with standardized tools, and thus we have a lot of contact with families, but not only on an individual basis, but also in a very systematic way. And we understood that it is also necessary not only to look at the patient, but to better and systematically understand the impact of such diseases on the family, especially on quality of life and the family's everyday life. And in fact, it was a PhD student, Luisa Amann, who stimulated us to do a study on the impact of severe rare chronic neurological disease in childhood on the quality of life of families. This was done together with Samuel Kröschel, Christiane Kehrer, and another PhD student, Saskia Fröhlich. The former two are from our department, and it concerned these two diseases, MLD and PH2, which are severe complex neurological disorders with a heavy demand on support and a reduced life expectancy. But the disease trajectory of these diseases is very different. While MLD, the leukodystrophy, has a three-phasic course, starting with a completely normal development. Then the child at a certain moment, it may be in early or later childhood, in adolescence, starts to fall out of its trajectory, stagnates, and after, again, a variable period of time, a severe regression and decline of motor and cognitive function occurs, and the child then stabilizes on a very low level with near to no communicative abilities anymore. In contrast, PCO2, pontocerebellar hypoplasia, has a primary severe developmental delay. So the children start already very slowly. They make very little developmental progress. They develop a lot of problems, movement disorder, epilepsy, severe infections, severe feeding problems. Before I had done systematic studies on these two diseases nationwide, and so we knew a lot about the disease, and we thought it will be interesting to compare these two dynamics also with respect of what it means for the families as a burden. So we started to do this study with a twofold methodological approach. On the one hand, we had a disease-specific semi-standardized questionnaire, and on the other hand, a more general questionnaire on the which is called the PETSQL, and we used the family impact module. The first was based on earlier questionnaires we had done, and it included validated scores with respect to language and gross motor function, so that we could classify the children with respect to their the severity of impairment. And it was about the severity of the illness, about the severity of the symptoms. It was about family support and the care situation. And it concerned also the non-affected siblings and the parents' work situation. The PET-SQL is a validated instrument which is used for a lot of situations, also with respect to diseases, and it assesses quality of life in parents and general family function. And I would like to show you a little bit what these two questionnaires mean, and I'll start with the semi-standardized questionnaire. I just give you as an example this question. How did you experience the time until diagnosis was established? And parents can rate between 0, not burdensome, to very burdensome. In fact, they rated that this time was very burdensome. And then we give them some possibility to add in free text how they experienced the time to diagnosis. And there came voices such as, despite the fact that my child changed, doctors were initially unable to find anything, which was very stressful for us. The diagnosis, at least, finally gave us an explanation. So it was also about this effect that diagnosis can be therapeutic in a way. And another voice, it was very, very distressing to see my child changing in pain and no doctor or therapist being able to help. Another question, who told you about the diagnosis? Was it an MD or another person? And how did you feel, or did you feel well informed after the diagnosis was given? And parents then could rate between not well informed or very well informed. And in fact, they rated something a bit in between, because of course, after a first contact with a lot of information, that is very difficult to be really well, to feel really well informed. But then, referring to the second question, were you satisfied how the diagnosis was transmitted? It was good to know that most of them were quite satisfied. And then, when we asked what was especially helpful, a lot of parents told us it was honesty, clear words, which could be understood, which was clearly understandable to them, and an emphatic handling. For instance, one parent wrote, the professor spoke openly about the cause of the disease, but very sensitively, always there for questions. And when we asked what was most disturbing, often came insensitive behavior, ignorance of the disease on the part of the doctors, as well as the passing on of unconfirmed diagnoses. For example, one parent wrote, the sentence, your child will die, has burned itself into my memory to this day. This sentence was said right at the beginning. So this means that is not the way to do it. Then, to tell you something about the PET-SQL, this has two parts. It concerns parent functioning and family functioning. And the first concerns physical functions, emotional, social, cognitive, and also communication and worry. And I won't read out all these aspects, but you can read that it is about anxiety, about feeling tired, about difficulty to remember things, about difficulty to handling own thoughts with respect to the child's illness, the child's future, and so on. And then family functioning concerns daily life activities and family relationships. That activities take more time and effort, and that the parents find difficulty or have difficulty to find time and energy to finish household tasks. And family relationships is about communication and stress and conflict between family members and difficulties making decisions and solving problems as a family. And now we come to the results, and we can see that the quality of life in the patients' families was, that is the blue bar, was decidedly lower than the yellow bar, which is in families with children without any chronic condition. And when you then look at the parent part and the family functioning part, it is also quite interesting to see that the most impact was on the family functioning, not so much on the parent functioning. And when we then wanted to know whether the severity of symptoms have any specific effect on quality of life for families, meaning is it more burdensome when a child has a severe gross motor dysfunction or a mild gross motor dysfunction, has a mild language or cognitive problem versus a very severe problem, we were quite astonished to see that the quality of life did not vary with higher or lower gross motor impairment, better or lower language skills. And the numbers which come after these items are each the total score, the parent score, and the family functioning score, so they are show no difference, sorry. And even when it concerns loss of independent eating and feeding with PEG, the quality of life was not changed whether this did already occur or did not occur, at least not in a significant way. Whereas the situation was more burdensome and the quality more affected when the impairment was extreme. That means when there was a complete immobility, or when there was a complete lack of communication, or when the child did not react to visual stimuli anymore. And especially, of course, also at the end, towards the time of death of the child, this advanced stage of the disease was also very burdensome for families. Now we come to a specific aspect of this study. We looked at mothers' and fathers' quality of life separately. And now comes a figure which is a bit busy. But you can see here the metachromatic leukodystrophy, mothers and fathers in dark red and dark blue, and the PH2 mothers and fathers in light red and light blue in comparison to families without children with a severe disease. And what you can clearly see is in any situation, mothers have a more severe show or report a more heavy burden of disease. That refers to the total score, that refers to the parent score, and also to the family's functioning score. And it is quite interesting when you look at the parent part, and here the light blue, the PH2 fathers, they were they reported similar situations as the controls. So it is in fact the mothers who have a significantly lower quality of life than in comparison to the fathers. And this is quite irrespective of the disease. We then asked in more detail about the professional situation of the parents and asked the question, how satisfied are mothers or fathers with their own professional development? And they could rate between very satisfied, 10, or not satisfied. And you can clearly see that in PhD as well as in MLD, fathers were quite satisfied with their professional development, whereas mothers, especially in the PhD2 group, but also in the MLD group, reported that they were not really satisfied. And when you look, you can give it also as numbers. 11% of fathers, whereas 56% of mothers reported that they could not achieve their professional aims due to the child's disease. And also here, I would like to give you some individual voices of the mothers who shows you what they felt, and that it is not always the balance between, the equal balance between men and women, but the higher engagement of a mother for her child, if I may say. I had to quit my part-time job because I just could not make it anymore because of bad nights, worries. I could not concentrate anymore. And I wanted to be with my child as well. That is an important aspect. That comes also in the next one. I want to take care of my daughter myself for as long as I can. And then also a typical situation, I get help from relatives in the household, but they think that they are not capable of caring for my child, which is often the case in in diseases which are very burdensome and have a lot of specific aspects. I told you also that we asked questions about the healthy sibling, and this was quite interesting to know that parents reported very different, or that the siblings reacted in different ways. Some reported negative results, that siblings were more depressed, more aggressive, or more hyperactive, but some also reported positive behavioral changes, that the child is very responsible and very helpful and has very good social skills. And also, we did not ask this question. 20% of parents even rated that the experience for the healthy child was both a burden and a positive experience. So, to summarize, severe rare chronic neurological disorders in childhood, and here one is severe leukodystrophy, are a heavy burden on the entire family system. And mothers prove to be particularly affected. More often than fathers, they missed out on or sacrificed a professional career in order to be able to care for the child at home. Healthy siblings reacted in different ways. And you have to keep in mind that living with an affected sibling is a burden on the healthy brother or sister as well. And they also need attention and supportive measures to protect their well-being. And especially time to diagnosis will prove to be very distressing, because it is usually very long in such rare disorders. And that means that we have to go on to further increase general awareness on these disorders, that it is so important that the gap between first signs and diagnosis is not too long. And we have always to tell, and we should not stop to do that and be active in that respect, to tell doctors how important it is to listen to parents who report that they are worried about development and behavioral features of their child, especially if these features have not been there before. And finally, the form and severity of the disease. That was interesting for us, and we didn't think that it would come out like that. Had near to no specific effect, with the exception that the end stage of the disease was experienced as especially burdensome. And to finish again with some parents' voices and wishes, and with greetings from a family with 2 affected children. Maybe an even better nationwide exchange between doctors treating rare diseases, since for most doctors it is the first time they are treating the disease, is something which is helpful, and that's what they are wishing. And ULF is the platform to do that, and has this as a very important aim. And the next one is also something which you can probably address most easily. One is so concerned with the care of the child that I wish the doctors would address you actively and communicate new information and insights. And that is something which is probably sometimes overlooked. We think that parents are always active, but we also have to consider that some are passive, and that we need to contact them. And again, you are probably in a good situation to support this. At the end, I would like to thank you for your attention, and I would like to thank all the families all around Germany, and this is Germany, what you see here, for their cooperation. And the study was done in Tübingen, which is in the south of Germany, in Baden-Württemberg, which is Swabia. It is not Bavaria, which is on the other side. And if you have no idea what Baden-Württemberg or Swabia means, I would like to give you some sort of red flag, so to speak, or some sort of flag. It is where Mercedes is, in Stuttgart, near to Tübingen, and it is also the home of the pretzel. And you see that both are not so far from one another. Thank you very much.
Thank you so much, Ingeborg. That was wonderful. The discussion will be at the end. You will be available for the discussion, right? That was just wonderful. Yeah. Then we go on to the presentation of Dr. Bertini from Rome, and that was pre-recorded.
Good evening, ladies and gentlemen. I'm presenting the experience from previous clinical trials on rare neurological disorders. This first slide summarizes a review of the literature about general recommendations for a successful clinical trial assuming an effective treatment. First of all, it is important to use a proper control. It can be a placebo control or a historical control. And then it is important also to increase the size of the experimental and control cohorts in order to increase statistical power of a given trial. And here we all know that there's a bottleneck for rare diseases. Then it is should identify confounding factors or environmental influences that can decrease the variability and reduce sensitivity to change. You have to consider the standardization of the clinical care, and you have to develop means for reliable measurements on the effect of acquired complications upon function. And in heterogeneous in disorders that have a heterogeneity in the phenotype, you have to try to increase as much as possible homogeneity of the original cohort in order to increase the statistical power of a given sample size, and then consider that surrogate outcome measures are less influenced by confounding factors. So the biomarkers can also be an important, generally they are secondary outcome measures. And then these biomarkers generally are direct measures of the intended biological response to stratify analysis and to correlate with the outcome, primary outcome variable. So now this slide in some way summarizes the main points that will be presented here about the lessons learned from clinical trials with experience in rare neurological disorders. So the first point is that pre-symptomatic or early treatment for several disorders improve the final outcome. And clearly defined endpoints are critical for showing efficacy. Efficacy can be easier defined when higher rate of disease progression occurs. Confounding factors increase in long-lasting chronic progressive disease and reduce detection of efficacy. And finally, the importance of defining target engagement from deduced and obtained from preclinical studies, and the importance of building up preliminary clinical pilot studies, perhaps as with an open design, with an open trial design. Now let's start trying to discuss the point about pre-symptomatic or early treatment that improves final outcome. It is known already from experience that several progressive disease models are not reversible after treatment. And this is the case for infantile ALD, metachromatic leukodystrophy, spinal muscular atrophy, Pompe disease, and Duchenne muscular dystrophy. Other conditions, for example, seem partially reversible, such as X-linked myotubular myopathy, when treated with gene therapy. In these cases, children are able to improve considerably after gene therapy in their motor function. The first example in treating pre-symptomatically neurodegenerative disease comes from the experience on X-linked adrenoleukodystrophy. As you all know, this disease, the infantile variant of the cerebral infantile variant of this disease is a devastating disorder. And in this protocol that has been designed by Patrick Aubourg now more than 10 years ago, gene therapy was delivered by hematopoietic cells, and the choice of presymptomatic or the beginning, the treatment at the beginning of the disease process has been critical to stop the progression of symptoms. Another example of success in a presymptomatic approach is the story of metachromatic leukodystrophy. As you all know, now after almost 10 years of follow-up, patients with metachromatic leukodystrophy and treated with gene therapy delivered by conditioning hematopoietic cells has demonstrated that symptoms do not appear when these children are treated presymptomatically. Early treatment efficacy has nicely been demonstrated in a preclinical mouse model where an ASO can target a exon splicing enhancer after a normal postnatal development at different time points. And as you can see here from this Kaplan-Meier curve, mice that are treated early at day 20 don't show any worsening, while mouse treated some days later at 25 days and 30 days manifest some symptoms of the disease. And interestingly, these different groups of mice treated in different time frames were studied by expression studies in the spinal cord, showing that when treated later on, treatment and rescuing the amount of SMN protein is not able to reverse the loss of a certain number pool of transcripts. So in this case, they nicely demonstrate that that what is lost during the course of the disease is irreversible. This slide summarizes most of the studies, clinical trials performed in spinal muscular atrophy with nusinersen. And here, this chart shows the mean total score for the HiNet, that is a developmental scale. And as you can see here, these trajectories correspond to the ENDEAR clinical trial, and that was addressed to the severe SMA type 1 patients. And you can see that the untreated patients with the placebo arm showed no developmental improvement, while patients treated after they were symptomatic, they showed some improvement. And here you have patients that were treated presymptomatically with spinal muscular atrophy type 1, and the green line corresponds to the patients that had 3 copies of SMN2. The blue line corresponds to patients that had 2 copies of SMN2. And you can see most of these patients, they follow a normal developmental curve when treated presymptomatically. A second aspect that we have learned from participating in clinical trials is that clearly defined endpoints are critical for showing efficacy. In the case of pre-symptomatic approach, the appearance or not of clinical manifestations of given disease treated pre-symptomatically can represent a clearly defined endpoint. And clearly defined endpoints are examples that come from the experience in clinical trials with spinal muscular atrophy type 1, the most severe manifestation of spinal muscular atrophy. Agent respiration failure, or an equivalent, is a clearly defined endpoint, and the presence or absence of a developmental milestone. Generally, the severe SMA type 1, there is no developmental milestone, while treated patients show clearly some developmental improvement in milestones. And then the achievement of a sitting position or the achievement of walking in a condition in which the natural history has shown that spontaneously there is no improvement in this direction is another clearly defined endpoint. For diseases with a slower progression, the loss of a certain functional ability, the loss or the persistence of a certain functional ability that is predicted for that given natural history is another important defined endpoint. And also, well, more classically, the statistical comparison of scores with a placebo arm and the achievement of some clinically meaningful function that is not predicted by natural history is another clearly defined endpoint. This slide shows you some examples of what I was saying before. Here on top, on your left, you can see a scoring chart for a developmental scale, the high developmental scale that follows developmental milestones of children and gives you different scores. And here, the example that I showed before, giving you the chart and the trajectory of patients treated pre-symptomatically versus patients that were treated symptomatically. You can see clearly the difference of efficacy. And on the bottom here, you can see the scale for CHOP INTEND. And the natural history represent the natural history of spinal muscular atrophy type 1. You can see that these children have a progressive loss of scores with a CHOP INTEND during the there is not a single child that shows spontaneous improvement with the scale. And here this is the CHOP INTEND of children treated with risdiplam, and on the bottom another schematic representation of improvement of children with SMA type 1 treated with a gene therapy. In all these cases, you can see that that they improve progressively, and you can consider that a score around 40 to 50 are children that obtain a sitting position. Another important point that derives from the experience in clinical trials is that efficacy can be easier to find when higher rate of disease progression occurs. And this has been quite well demonstrated in SMA clinical trials, where the rapid approval by regulatory agencies mostly occurred because efficacy was obtained in the most severe subgroup of the spectrum in SMA type 1, known to have a high rate of progression. And also in DMD, Duchenne muscular dystrophy clinical trials, a more significant evidence of efficacy by post-hoc analysis was obtained in subjects that were walking below 300 meters with a 6 minutes walk test, and were then predictably losing ambulation faster in the time frame of 2 years. The following slides give you some examples on what I was saying before. So here you have on your left, you have the trajectories corresponding to the most severe SMA type 1 variant. And these reflect the natural history of the disease, in which you have progressive reduction of the scores with a CHOP INTEND scale. Well, on your right, you can see that always the CHOP INTEND scale scored during time shows that trajectories are going upright, meaning that there is a clear evidence of improvement in a period of relatively short time. Here you can see that the period is around 13-15 months. Here in this slide you can see in a clinical trial for Duchenne muscular dystrophy, patients treated with Translarna, that is a molecule that has been demonstrated to increase the levels of dystrophin in this subgroup of Duchenne muscular dystrophy patients with a nonsense deletion in the dystrophin gene. And by natural history data, you can see that the baseline for walking ability under 350 meters, covering 350 meters during the 6 minutes walk, predicts decline of ambulation in the period of 2 years. Here you can see on your right the trajectory for patients that were walking over 350 meters, and here the trajectory of patients that were walking below 350 meters, and in these patients the decline and loss of ambulation is predictable. And this slide, always taken from data of the trial with Translarna in Duchenne muscular dystrophy patients. In the upper slide, you can see that taking into account the whole population of treated and untreated patients with Translarna, there was a delta of improvement in the treated patients of 31 meters, while pre-specified subgroup, considering the pre-specified group with a baseline of the 6 minutes walk under 350 meters, patients showed a more clear decline in the placebo arm, and showed overall the study showed that there was a higher delta between the treated arm and the placebo arm. In some way showing a clear efficacy, a more clear efficacy of the treatment. Now, another important point when considering clinical trials is to take into account confounding factors that increase in the long-lasting chronic progressive disease and are able to reduce detection of efficacy. So in long-lasting disease, particularly those diseases that have an impact on motor function, several modifications occur, such as joint contractures or abnormal weight gain or muscle wasting, or increasing deformities that are known as confounding factors. And these factors contribute to reduce the opportunity of showing efficacy compared to a placebo arm. So this slide exemplifies what I was saying before about confounding factors. Here on your left, you can see a sketch that summarizes the CHERISH trial, that is a double-blind, sham-controlled phase 3 study in which children with chronic SMA were treated with nusinersen. And you can see that the changes with the scale, with the Hammersmith scale, were much more clear in the treated arm, that here indicated in red spots, if you compare them with the gray triangle that are the placebo arm. And so if you go along with the elder patients, consider elder patients, this difference with placebo was not so evident. And here again in the Risdiplam trial in chronic SMA, that this sketch divides patients in different subgroups, and you can appreciate that the change of more than 3 points, with the magnitude of changing more than 3 points with a scale MFM32, was much more evident in the group of 2-5 years compared to the other subgroups of 6, 11, 12, 17, and 18, 25 years. Finally, the last important point is to consider target engagement defined in preclinical studies, and also the importance of starting with clinical pilot studies to approach treatment of a given disorder. So target engagement is the key in vitro and in vivo tool that can improve the probability of success for a given compound and become a pharmacodynamic readout for in vivo studies. The pilot study is a small-scale study conducted in preparation for larger research to increase the likelihood of a successful future RCT trial by exploring the efficiency, internal validity, and fundamentally the delivery of the proposed test, dose escalation, intervention delivery, data collection methods, and adherence to the study protocol. Pilot studies can provide empirical estimates of treatment's effect size, which in turn can be used to calculate sample sizes for future statistical power for future trials. Here you have 2 examples of what I was saying about biomarkers that in the upper part of the slide, you can see the measurement of the SMN protein in patients that were and compared with a placebo arm, the levels of the SMN protein measured in the serum of patients that participated to the clinical trial, SUNFISH, the dedicated for chronic SMA. And in the bottom, the preclinical studies in the mouse model demonstrating that Translarna was able to increase the levels of dystrophin, and this was also demonstrated in the PIDA study in Duchenne muscular dystrophy patients, showing clearly that the patients that were treated orally with Translarna had an increase of dystrophin in the muscle biopsy. Thank you for your attention, and I am closing this presentation by showing you a photograph of all the team that works with me. It is a team made of clinicians and PhDs that work in the lab, and as you can see, there's a clear predominance of females in my team group.
Hello everybody. First of all, I would like to thank the organizers for allowing me to present the second time in a row at the ULF. My name is Menno Stellingwerf and I'm a PhD candidate at the lab of Mario van der Knaap. The last couple of years, I managed the Vanishing White Matter Registry. And today I want to talk to you about its current use and its future use. First of all, what is the Vanishing White Matter Registry? The registry is an online successor of the Vanishing White Matter database, which was the basis of the natural history study. Over 300 genetically confirmed patients are included from over 40 countries. We include genetic testing results, brain MRI scans, clinical information from hospitals, and online questionnaires. These questionnaires can be filled in by either patients, physicians, or parents of patients. And we ask quite frequently for these questionnaires to be able to look at the progression in time. The data are coded and saved in a secure database, which adheres to strict privacy regulations. If you would like to know more about what it involves to participate, you can always email us at the email address at the top of the slide. The data in the Vanishing White Matter Registry has already taught us a lot about the disease course and the clinical characteristics of vanishing white matter. We, for instance, know that most people have their onset before the age of 8, while some only have their onset in late adulthood. We were also able to look at the disease course, and in these two graphs, the x-axis shows the disease duration, and the different colored bars show different disease or age of disease onset groups. Now I would like to zoom in on the green line and the red line. The green line contains patients with an adult onset, and the red line contains patients with an onset between 1 and 2 years old. And for the patients with an adult onset, we look at ambulation. They don't lose their ability to walk until late in the disease. And this is not the case for patients with a very early onset, between 1 and 2 years old. They lose their ability to walk quite early on in the disease course. Now, if we look at cognitive decline, we see that both the red and the green line go down quite early in the disease course. So for both patients with a very young age of onset, as for patients with an adult onset, we see cognitive decline from quite early on in the disease. We were also able to look at the progression on MRI scan for a large group. Here I show 6 images of 3 patients, and the top row contains MRI scans which were done quite early in the disease, and the bottom row shows the last MRI scan for each patient. Now if we first look at the first patient, we see that in the middle of the MRI it is black, and actually that's the case in all the MRI scans. So in this type of MRI scan, what's black is water, or water is black, depending on how you see it. That's actually normal because that's cerebral spinal fluid in the ventricles. But if we look in the white matter, we also see that it's black, and that's abnormal, and that's indicative of decay into water. If we look at the first patient who had a very early onset, and we move 1 year later to the last MRI, we see that practically all white matter has fully decayed into water. That's not the case for the patient who had its onset around 8 years old. At the beginning, we do already see that the white matter is abnormal because, as you see, it's dark. 17 years later, we do see that there is slight progression of the MRI abnormalities, but not as much as in the first patient. And in the last patient, that's patients with an adult onset, we don't see clear differences between the first MRI scan and the last MRI scan, even though there was an interval of 7 years. Now, of course, these are 3 patients, but we have quantified this progression for many more patients. And in these graphs, every dot represents an MRI scan. And if 2 dots are connected, that means they come from 1 patient. The higher the dot on the graph, the worse the white matter on the MRI. If we look at the graph on the top left, this graph represents MRI scans of patients with an age of onset before the age of 1. While if we look at the bottom right, we see the MRI scans of patients with an adult onset. And you can probably already see that the slope is much steeper in the younger age of onset groups than it is in the older age of onset groups. And that indicates that the progression on MRI is much faster in the younger age of onset groups. So this is what the registry has already taught us by now, but it can also play an important role in setting up trials. And because the Vanishing White Matter Registry contains so much data, we can set up realistic and relevant inclusion criteria and also outcome measures. Besides that, most trials have a so-called run-in period. And during this run-in period, basically the patient is not receiving the medication of interest yet, but baseline measurements are being performed. And perhaps the Vanishing White Matter Registry already contains these baseline measurements and sometimes even observations from several years ago. So that can be quite a big advantage of the registry in upcoming trials. Now, currently the registry is Amsterdam-based, but as you see in this session, we do work together with other Vanishing White Matter experts throughout the world in the Vanishing White Matter Consortium. And our plan is to change the governance of the registry to facilitate Vanishing White Matter research actually worldwide. There are quite some steps to make this transition, and a new PhD student, Irene van Belen, will work on this project from August onwards. This could be a suggested governance model of the Vanishing White Matter Registry. So first of all, there's a board, and this contains all the consortium members. So Vanishing White Matter experts who make decisions about various projects and also assess data requests. Then there should be an executive board dealing with day-to-day business. The executive board should be supported by a team, for instance, to deal with legal issues. And besides that, we would love to see an advisory board with various stakeholders. And these could be patient advocates, but can also be other experts and, for instance, the Industry Alliance Office. Finally, there are various projects which can focus on a specific part of Vanishing White Matter research. And every project could have a different project group. I would like to conclude with showing an example of how we think the Vanishing White Matter Registry could work in the future. As you see, there's a researcher somewhere in the world who wishes to get access to a part of the data. And then the Vanishing White Matter Consortium looks at the request, and if the Vanishing White Matter Consortium agrees, they will allow the researcher to receive part of the anonymized data. And an example could be that a researcher starts a trial, and the researcher would like to receive information about the motor skills of the previous years from the patients that actually are included in the trial. So then the researcher will file a request for those specific patients for the motor skills, and then the consortium would agree that the researcher receives that specific data. And with this structure, we ensure that the data does stay anonymized and secure, but that progress of Vanishing White Matter research will still be facilitated and is not dependent on only one center. So thank you very much for your attention, and hopefully next time we'll be able to meet actually in person.
Thank you very much, Menno. I think it's quite an achievement we have to start all over again and then still stay in time. So we have now the possibility for a general discussion. And the most of the speakers are still available. I saw that some speakers who had a pre-recorded talk are also still in the audience. So I would like to give people the opportunity to start to ask questions. And I think I would prefer to, because there might be some questions about guanabens, that we keep those for the afternoon. But I see people, faces coming to be seen. So is there anybody who would like to ask a question?
Hi, Mario.
Hello.
Hi, good to see you again. Thank you so much for moderating the conference. It's been fantastic. As you probably remember, I do a lot of work in ALS. And certainly we have mutual friends in Utrecht with the TRICALS consortium. And one of the things that we're really pushing in the ALS space is combination therapies, right? And one of the things that I was wondering about how you feel is the idea of doing something similar in ALS, and that is testing multiple compounds with different mechanisms of action together to look for synergistic effects. Because certainly in ALS, almost all the major key opinion leaders believe that the future of ALS treatment will be combination therapy. So, thank you.
Thank you so much. It's lovely to see you. We have been saying this for years now, that we call it multimodal treatment, that I don't believe in one miracle drug that's going to cure everything. And yesterday we had a beautiful presentation on Krabbe disease, for instance, where you can see in those Krabbe dogs, which are really a good model of the disease, that a combination of hematopoietic stem cell transplantation and high dose gene therapy is much more effective than any of them separately. And so there will now be a combination trial in Krabbe disease. And we are setting up for testing combination treatments in our vanishing white matter mice, certainly. So I agree with you that in the end it will be probably, as I envision it, it will probably be a cocktail of drugs, and then hopefully, for instance, gene therapy to cure the most affected cells, and then stem cell therapy to hopefully repair something of the brain that's already affected. But we are talking about many years. I totally agree with you. And I would also like to take away from the audience the impression, perhaps that we may have given you, that there is a miracle drug out there. We are all a little bit worried about that. It might be that definitely drugs might modify the disease course, but that vanishing white matter is a fundamental disease. It's deep into the biology of every cell of the body, and that we can simply cure the disease with a drug without many side effects is something that I think is a little bit overstated. I don't see that happen immediately. Yeah.
Thank you.
Maybe Mario, I can add to that. Thank you, AJ, for your question. And I think the talk of Peter described the adaptive platform trial design. And I think that would be a very suitable construction to add several arms to already ongoing trials. So if initial results with perhaps single treatments show any efficacy, or there's data from preclinical studies showing that combinational treatments may be effective, then I believe it would be relatively easy to add an arm combining such treatments in this trial design, which would be much easier than setting up a complete new trial. So I think the construction would be very in favor of those combinational therapies.
Yeah, I fully, you know that I fully agree with you, Priska, but that also makes that we have, as a consortium and as parents and families, to convince the companies to participate in a platform trial, which is not so easy because the platform trial will not completely determine then the trial, but will come with a minimum set, for instance, of outcome measures that's shared. They need to be willing to discuss sharing controls. I would be extremely proud of us if we could convince companies to work with us on a platform trial, because I think in the end it will be beneficial to everybody, also to the companies.
Yeah, I think one difficulty is that treatments that are now being investigated are in different stages of development. Yeah. So ideally, when you would want to start a platform trial, you want to have everyone on the same page at the same time. But that is not the realistic scenario. I think perhaps some treatments will be sooner ready for clinical development, perhaps depending on whether they are repurposed compounds or new compounds, whether there is already existing safety data, if there are data from the rodent models available, or whether this still needs to be investigated. So the timing might determine the success of that design as well.
Yeah, I'm not sure if because I'm sorry for my clock. You can hear it's ahead of time. That's my neurosis. I'm always ahead of time. But if we would set up a platform trial with a minimum, let's say, skeleton. You also hear that I have multiple clocks, or just in case I would not have heard one clock. But I'm sorry about that. But if we would have a core design with and also companies would be would have the possibility to add to it. So we would come up as a consortium with a core design, and companies would be able to add to it, but the core design would be sort of obligatory. Then it could still work.
Yeah, I agree. Yeah.
And perhaps as parents and families, you may have thought, why this consortium and why spending so much effort and time on it. But this is it. This is why I think we need to join forces, and also with patients and families, in order to coordinate it, in order not to let it end in a sort of, a web of all sort of trials going on, and you as parents having to decide which trial is my child going to participate, and how do I do that, or how my spouse with Vanishing White Matter is going to participate. I think this is exactly where the need of the consortium comes in.
So Mario, and Priska, if I may add, if you take the experience of the Healy platform trial in the United States, which is for ALS, which started a little less than 2 years ago, actually, maybe 18 months or less, that has been very successful. I mean, it's had its, especially with COVID, some starts and stops. But it's a perpetual trial design, and drugs and companies can come onto the trial at different points in time. And so you can start with 1 or 2 drugs that are ready to go, and just gradually drugs come on and drugs come off at different points in time. So it certainly is possible. And certainly I think we can learn a lot from the experience of both TRICALS and Healy.
And I think we come with also advantages, because if we set it up this way, then we come with a control group that's gradually also growing, and we come with an organization. And so I think it comes with limitations perhaps for companies, but it also comes with benefits and advantages. Yeah.
Yeah, and I think we can learn a lot from the ALS field. The ALS community is very well advanced in this type of trial. So I think having the connections with them is extremely helpful.
Yeah, if I may say so, ALS is much less rare. And so the numbers of patients in the vanishing white matter field are much more restricted than in the ALS field. So it comes with degrees of freedom, having these bigger numbers, and we are much more limited. So every patient is something to think about, how we deal with that. Yeah. But thank you for the question, AJ. That was very helpful. I'm reading a question from the audience, and the question is what onset is. And onset, actually, onset is I agree with you, not a good word, because onset feels like the disease is starting then. Actually, we should say age of presentation. It's the age that it becomes clear that something is wrong. So that's what we mean by age of onset. Other questions?
Yeah, could I ask just a question, maybe more specific to my son, but also maybe others might have a similar concern. We're experiencing more and more anxiety episodes with him. Right now we have him on some medical cannabis, but it's hard to diagnose a little boy that weighs 40 pounds on what exactly we should be giving him for that. So I was just wondering if you had any insight there, or maybe a drug that is existing outside of the medical cannabis that could assist us with what he's experiencing.
Yeah. I'm not sure whether anybody has an advice for you. It's of course very difficult for me because I haven't seen your son, and it's difficult for me to see what's happening to him. You must have discussed this with his neurologist, I guess. And did you get a good advice?
We have, yes and no. We aren't necessarily seeing a rare disease neurologist, or specifically a leukodystrophy specific one, which we are on the fence on whether we should be traveling to see one or not. So it's the advice we're getting usually is kind of at our discretion because of the unknowns there.
Yeah, perhaps you should be a neurologist that's acquainted with leukodystrophies, because the problem that you are addressing is not uncommon. Anxiety and also, being restless or whatever. And I think it would be a sort of cheap advice if I would give advice to you, whereas I've not really assessed the problem.
Sure.
I would go and see a neurologist that knows about leukodystrophies.
Okay.
I think there's a lot of things that could be developed to help parents. I don't know if it would be part of the consortium, but it would be like how to talk to the school, how to communicate the disorder. And actually years ago, MS, I found on their website, does a really good job of how to talk to teachers and kind of that process, the IEP. And that's probably out of your realm, but it's also how to talk to doctors, or it's almost looking at the awareness and kind of our path or journey and establishing what we need at each point.
Yeah.
And I think that's more of a motive than a clinical or medical thing. And that could be extremely helpful. And I'm wondering if that's not something we as parents can help do. And the fact that I've worked in a lot of rare diseases, and that's what we've done to help pharmaceutical companies come up with communications.
Yeah, I just thought of two answers. One is what you saw in both my presentation and then Priska's presentation, that we have set up a website. And I think what's right, that there might be more information on the website on specific needs and specific problems associated with vanishing white matter. And I totally agree with you that you as parents could help with that. And I was just thinking of what's actually fantastic is that you have Donna with the ULF as an advocate for vanishing white matter. And perhaps Donna, I was impressed by your presentation. Whether you could also help the parents coordinate getting this information together.
Yes, thank you, Dr. van der Nepp, thank you. Sure, I mean, I will definitely.
And I think, Priska, we can facilitate with the website because that's the website of the consortium. And we could also make pages for parents. Don't you think, Priska?
Absolutely, and I think that's why we are very happy that we are already partnered with the family, patient and family foundations, the leukodystrophy associations, and I think we can only expand that and see how we can help you better. I think the website is a start where it is right now. It was launched this week, but it's far from finished. And I think any suggestions for expansion or a way of interacting with each other would be very much welcome.
Yeah, and I'm always advocating being collaborators, companions, how you call it. So I find your suggestion that you as parents can also, you are knowledgeable about the disease and you can come up with information and text and we can look at it. It helps. I think we have still 3 minutes because Keely was very strict that we needed to leave at on time. Is there anybody who wants to use the 3 minutes?
Well, if no one's talking, you know me, I can talk. So I'm just still going to say on behalf of all VWM families and parents and everyone, we just want to say thank you very much for your time to, you know, Priska, to Mano, the student, I mean, everyone, you know, and everyone that put the consortium together. I mean, the families are beyond grateful for everything that you're doing. I mean, you know, and giving them hopes. So we just cannot say thank you enough. That's all I can say.
Okay, thank you so much for your kind words, Donna. And I'm very pleased that we have you as an advocate for vanishing white matter. Then we'll close the session and we'll be there in 1 hour and 15 minutes sharp. And you hear that I have multiple clocks, so I will be there in 1 hour and 50 minutes.
Okay, thank you.
Thank you so much. Thank you.
Thank you, Dr. Van der Nepp. Thank you.